Borodar, good morning everyone. Welcome to Betsy Cadwallader University Health Board meeting. I'd like to extend a very warm welcome to you all. As many of you will be aware, this is the first meeting which is to be live streamed. Due to the continuing restrictions in respect to public meetings and essential travel, we are broadcasting live so that hopefully those who wish to observe the meeting in real time can do so. Due to the current limitations of the software, I'd ask that anybody wishing to speak in Welsh does so, and I would encourage them to do so. But can you kindly translate what you have to say in Welsh into English for the rest of the board? Thank you. Before we start the formal business for today, I want to extend my personal thanks and appreciation, and that of the board, to all those members of staff who have been working tirelessly throughout the pandemic. The prevalence of COVID-19 in Wales is low at the moment, with only a small number of people testing positive for the virus each day. My thanks go out to our communities without whose support we would be seeing a very different picture. Across Wales, currently only around 0.5% of COVID-19 antigen tests carried out are positive. At the height of the pandemic in April, 48% of the tests were positive. The number of people who are dying from COVID-19 has fallen to single figures, and we've seen a number of days in the last week or so where no deaths were reported. Whilst these figures are positive, they in no way reflect the tragedy of the situation for the individuals and families affected, and our condolences are extended to all those who have lost someone throughout the pandemic. Until a vaccine or an effective treatment for COVID is available, we'll be living with the virus. A key part of containing the spread is the Test, Trace and Protect programme. And this is Welsh Government's approach, as you know, to testing and contact tracing to help us live with COVID-19 and resume some elements of normal life. The TTP programme in North Wales has helped identify two significant outbreaks, one in Anglesey at the Two Sisters poultry processing plant and the other in Wrexham's Rowan Foods. The North Wales TTP programme, which started on the 1st of June, is a multi-agency partnership effort. The Health Board is the lead agency, driving the programme forward with colleagues, and we are currently antigen testing around 5,500 people every week for COVID-19. For our 4 testing sites at Ysbytai Outwen, Park Menai, Ysbyty Glenclwyd and Wrexham Myler Hospital. These sites are staffed by Health Board colleagues, and the samples go to Ysbyty Glenclwyd, which has a current daily capacity of 800 tests, and to our South Wales laboratories for processing. Over the last few weeks, this capacity has increased and will increase to around 1,400 tests a day. In addition to these local testing sites, 2 UK government mass testing units are in place across the region at Deeside and Llandudno. They are staffed through UK government arrangements, and the samples are processed through the Lighthouse Laboratory in Manchester. Home testing kits are also available for the public to use, and the testing of some care home staff continues in line with Welsh Government guidance. Supporting the TTP programme is a significant operation across the region, and this will be vital over the coming months as we prepare for the winter and the annual flu season. And we are working with multi-agency partners to proactively communicate and engage with all our communities to raise awareness of the programme. So our thanks go to all those involved in this crucial work to protect our communities. There are 2 other matters I want to update on at this point. The first is the fact that together with Bangor University and other partners, we have submitted a proposition to Welsh Government for a medical school and health sciences school here in the region. Secondly, on Monday, we shortlisted 3 candidates for the position of Chief Executive Officer, and the selection process will be held on the 6th and 7th of August. I'd like to thank Simon, our interim Chief Executive, for all he's doing to support us in this intervening period, and all he will do to support us over the coming weeks. So thank you, Simon. So before we move on to the main agenda, I need to extend and record to you a number of Chair's actions which have been agreed since the last meeting. And these are, firstly, the Clysmeddic contract. I ask you to note that the Health Board Chair approved the awarding of the Clysmeddic contract to Dr. MB and Dr. MT of Corwin House Surgery, Penygroes, and to approve the provision of limited financial support to enable the new contractor to take over the contract and emerge into the provision of GMS services in Penygroes from the 1st of September 2020. The second is the Q1 plan approval, and I ask you to note and approve the fact that at the request of Cabinet meeting held on the 28th of May, the Health Board Chair was asked to approve the draft Q1 plan to support service delivery during the pandemic. And finally, ventilator procurement. And I ask you to note and approve the fact that the Chair was asked to approve the purchase of 52 Draeger Perseus invasive ventilation machines to meet the anticipated demand of COVID patients requiring ventilation in the event of the anticipated surge and based on our current predicted modelling. Thank you. So, without further ado, we will move into apologies for absence. And I received apologies from Professor Nikki Callow, from Gareth Evans and Michael Rees. Professor is deputising for Gareth as the Vice Chair of the Healthcare Professionals Forum. And finally from Sue Hill, and we've got Eric Gardner deputising for Sue. So, declarations of interest. Does any member need to declare an interest on any agenda item?
Yes, Mark, it's Frank on here. I need to declare an interest on item 3.2, the test, trace, protect update, due to adverse involvement with the Bangor testing station. Thank you.
Ga i hefyd, Mark, datgan diddordeb ar yr un item. May I also declare an interest on the same item? I'm a member of the ADRA board.
Okay, thanks to you both. So we now move on to the minutes of the 14th of May and the 21st of May. Can I first of all take any points of accuracy on the first set of minutes, i.e. the 14th of May? Are you happy to approve those minutes?
Yes.
Yes. Yes.
Okay, thank you. So we move on to the minutes of the 21st of May. Are you happy to approve the minutes of the 21st of May?
Yes.
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 Thank you. So we now turn to the actions arising from those meetings, most of which are closed, but I just want to pick up on a couple of points from those closed actions, if I may. So, and please stop me as I work through the closed actions and we come to the last open action. So if I deal with the first action, which is shown as closed, and this is directed to Chris Stockwell or one of his executive team colleagues. So the action refers to the recovery arrangements. So it would be helpful to know how the executive team is proposing to capture the learning from what we have encountered during COVID and continue to encounter, and what we've done to improve our response to COVID and to delivery of services. And secondly, how the regional recovery plan, board is working and our participation in that. So first learning, secondly, how we're taking recovery forward. Could someone comment on that from the executive team, please?
Okay, thank you, Chair. I'll pick that up. So in terms of the learning, as an exec team, we're absolutely clear that the journey that we've gone on in what's in the order of about 20 weeks has been a significant one, and one that will continue on on that basis, have started to pull together a clear plan which captures learning, not just in terms of the areas that we'd wish to continue and develop, and there are areas such as IT developments there, but also those areas where we would choose to do things differently with the benefit of the last 20 weeks of experience. That's supported by my clinical exec colleagues, as well as the rest of the exec team, and the proposal is to bring together a clear plan which we can share at future meetings and intervening meetings. I think it's really important that we capture the learning from all individuals across the health board, and not just those individuals that have been in a managerial role, and that requires a careful thinking in terms of being able to capture some of that learning. individuals are working through that. I'm not in a position to be able to provide a clear paper on that today, but I'm happy to bring that forward. In terms of the recovery processes and how we're working in partnership, I'd have to say one of the huge opportunities that I believe partners in North Wales have captured and made the most of is how we can work more productively and creatively together. We started off with a multi-partner group that was very focused upon the strategic delivery of the height of the pandemic. We're now moving that into a recovery partnership called the RCG, which brings together all partners and helps focus our attention now in terms of how we get back to a business as usual, not simply just a health based business as usual, but how we bring all of our businesses within North Wales back into a position where we can move forward in the vibrant way that we need to do. It's chaired by one of the local authority chief execs, and we attend every meeting as well as interim meetings. And a number of us as execs contribute to that, including myself and the Director of Public Health.
Thanks, Chris. I believe Mark Wilkinson, Director of Planning, wants to come in too. Mark?
Yeah, thanks, Chairman. I just wanted to build on Chris's answer there and make reference to work that we're doing with our partners as well. As part of the regional partnership board across North Wales, there's something called the Research and Innovation Hub, and that's also doing some work to capture some of the learning that we've seen so far from how partners across health and social care have responded to the pandemic. So we're looking to make sure that we align that partnership work with the work that we're doing internally as a health board in the way that Chris has just explained.
Thanks, Mark. Does anybody have any questions in terms of what's been said as regards that first action? No? Okay, so I'll carry on. I'll assume there is acceptance of the actions being closed in the table, but in the absence of hearing someone say to the contrary, I'd like us to take us to the action of the 21st of May, the first, David, which concerns the 2 points that we agreed in terms of the task and finish group, i.e. to undertake a clinical review of some amputation cases, and secondly, to look at the potential practice of over-reliance on antibiotics. Whilst there's an update there, I'm conscious of the fact there was a meeting on the 17th. So David, are you able to respond more specifically to those two actions, please? David, I think you're on mute.
Sorry, Chairman. We met on the last Friday. It was a second meeting of the Vascular Task and Finish Group, and the meetings are going very well. That's later on the agenda. But we had two very detailed presentations. The first was from one of our pharmacists, Charlotte, who's an expert on antibiotic resistance, and she provided a very detailed description of what is potentially a worrying relationship between very high prescribing of antibiotics over previous years in the vascular service, mainly in Ysbytai Gwynedd, and quite clear evidence of antimicrobial resistance, particularly in Ysbytai Gwynedd. So we're going to continue to explore that data. The formulary, the prescribing options have been narrowed for a number of years to try and avoid any unnecessary use of antibiotics. But clearly there is a relationship that we need to understand so that we learn from previous working arrangements to ensure that we don't introduce resistant bacteria into the hospitals, because it can take many years sometimes for that to be eradicated. So the pharmacist, Charlotte, will work as part of the task and finish group and continue to develop that work, and it was very well received. So we're building up a very good understanding of the antibiotic prescribing and lessons to be learned. The second presentation was about the amputation. And there are two key parts to that, and it was well received. Firstly, to undertake an audit of the practice of amputations to ensure that we're getting informed consent, that we're understanding the NICE guidance threshold for amputation, and that will be a review of potentially up to 50 cases, and it'll be fed back through the vascular task and finish group. The second important aspect, and it came out to the review that was presented to the board, is to do a much more detailed analysis of comparator sites using existing databases such as CHKS and the National Vascular Database, so that we can fully understand the patterns of amputation. We also think there has been a recording issue that perhaps some toe amputations in the past were undertaken not in the operating theatres but in clinic areas, which is a safe way of doing that, but it may not have been recorded every single time. So there's a lot of work has been started around this. The important thing is the group is working as a group. I'll talk later about the engagement of CHC and patient representatives, but we've been able to start this work, I think, with experts who understand the field, presenting the work. We'll continue to monitor that and report it to the Quality, Safety and Experience Committee at each time. So I'll finish there.
David, while you are talking about vascular, could you just give an update, please, in terms of the exchange with one of our medical colleagues, Anthony Dixon, around the foot service?
Certainly. So for board members, one of our colleagues has written to myself and the chairman, and we've been trying to find ways of engaging the entire spectrum of professionals involved in foot care. And we've provided a response, and this was actually a topic of discussion at Friday's vascular meeting, because it's important that it is seen as a multi-professional pathway, particularly with podiatrists, diabetes specialists, orthopedic specialists, as well as vascular specialists. And we're going to work with Anthony and colleagues to develop the pathway. It's becoming, I think, possibly the most significant pathway change for the vascular work. And I've been impressed by the enthusiasm and willingness of colleagues from across the health board to work in a partnership approach to this. So there's a lot of willingness and a lot of eagerness to develop a better pathway. So we'll be working with Anthony and colleagues to learn from examples of individuals to ensure that we can develop the best possible service. So it's an indication that people are coming forward with ideas, they want to engage in the work, and we'll be responding to people such as Anthony, engaging them and working with them to keep developing a better service.
Okay, thanks, David. So can I move on to Sue Green in terms of the outstanding action, which is also related to what we saw in terms of the vascular report and the feedback from the CHC, but more broadly covers whistleblowing and our safe haven arrangements. Sue?
Certainly, Chairman. So I can Burnley, as you just heard, and Jill Harris and I are working together to make sure that not only the policy but the availability and the opportunity for staff to raise concerns is I think very clear to individuals. We also can then publish really clear information as to what happens with concerns when they're raised. How will people's identity be kept anonymous if required? So we're working together to develop some proposals. We want to make sure that we properly engage with staff and our trade union and staff representatives. So we would be looking to bring a proposed policy back to the Remuneration and Terms of Service Committee at the October meeting, which is on the 5th of October.
Okay, thanks, Sue. So we move off of the actions table, if everyone is happy to do so, onto items for consent. And the first, David, rests with you, and that's the Mental Health Act approval of clinicians and associated matters. David?
Thank you, Chairman. So this is the regular list of people joining and leaving the statutory register. This relates to specialists, mostly psychiatrists, but sometimes general practitioners who have deemed to have a degree of expertise and specialist knowledge of the Mental Health Act. So this is a statutory arrangement to ensure the safeguarding of patients and vulnerable people, that people operating within the Act have governance and the appropriate qualifications and experience. So it's for approval. Thank you.
Are colleagues happy to approve the list?
Yes.
Okay, so we go with the recommendation, which is listed, and to ratify the attached list of additions and removals. Thank you. Thanks, David. So we then move on to the next item, which is document signed under seal. Dawn?
Yes, Chairman, this is the regular update we bring to board in accordance with standing orders to present those documents and contracts that have had the seal applied. So it's here for the board to be aware of and to note. That's really all I need to say, unless there are any questions.
Thanks, Dawn. So are colleagues happy to note the document signed under seal?
Yes.
And move on?
Yeah.
Okay, thanks very much, Gogledd. So we then move on to, thanks, Dawn. We move on to the annual assurance report on compliance with the nurse staffing levels. Jill.
Thank you, Chairman. This report, for your information, has gone through our Quality, Safety and Experience Committee, and there was considerable conversation during that meeting. The paper outlines our responsibilities under the Act and the areas to which we have to comply. What it also outlines, in line with the Act, is the harm that's that has occurred in areas where we haven't managed to achieve the staffing levels that we would wish to have in place. The key points to make from this is some of the audit work has not been undertaken as a consequence of COVID. We know that we've had staff moving and redeployed as a consequence of responding to the outbreak, and we've also seen wards redesignated. However, what this does outline, as I say, is the audits that have been taken place and the consequences of harm where that has been less than satisfactory. I'd also like to point out that we do have, and this does outline that we do have vacancies across the health board. We are working closely with OD colleagues, workforce and OD, to close those gaps, and we've been really fortunate with our students from Bangor University who are taking up posts within the organisation. That's been really excellent, and I would like to take this opportunity, if I may, Chairman, to thank those student nurses, hopefully will be our staff nurses very shortly, for stepping forward during the pandemic as well to provide support to the wards. So this is for receipt for the board, and I'm happy to take any questions.
Jill, any questions for anybody? Okay, Adrian, I believe you want to comment as well.
Yeah, please, Mark. Thank you. I think Jill taking the opportunity to thank the nursing students who've come forward with.
Adrian, can you speak up? Sorry, we can't hear you.
Can you hear me now, Mark?
I can, yes, thank you.
Okay, thank you. So I'd just like to take the opportunity as well to thank all of the therapy students and radiography students who've also had temporary registration, and many of whom have started early as well, and also for the students who've come in from year 2, similarly to the nursing students, really appreciated by the service. Thank you.
Thanks, Adrian. Jill, I've got a couple of observations, if I may. So the first arises on page 1, where it's noted that there are a series of reviews which have commenced in areas where nursing services are applied, commissioned, and you include a list. Presumably, Jill, those reviews are, as it says, commenced, proceeding as you'd expect them to, and any learning that we identify will be shared with board?
Yes.
Okay, thank you. Can I also draw your attention to the first table as such, where it lists hospital acquired pressure damage, and you'll see whilst it's not said to be associated with the staffing levels, there has been a rise in those incidents at YGC from 16 to 25. Any particular concerns? Any response that is underway to address that if there are particular concerns, albeit I recognise it's not connected with staffing levels?
When we first of all we review each one of those, Chairman, and staffing is part of the question that we do ask. Has staffing had an impact? But as a consequence of this and a number of other issues within YGC, we are conducting a safety review across the site to see what wider lessons learned can be learned and put into place, not just within YGC, but across the health board. We still have the collaboratives in place, but they have been paused during the COVID outbreak. So, so we are taking actions forward, Chairman.
Okay, thanks, Jill. And then, so we've been asked to note the report, but Jill, I guess we're also being asked to note the specific recommendations that are listed on the final page. You'll see it in the final paragraph with bullet points. So there are a number of things that are taking place in terms of next steps that you're asking us to note too.
Yeah. Sorry. Yes, please, Chairman.
Okay, so with that in mind, presumably board are happy to note the report, but also note the those recommendations and next steps. Are members happy to do that?
Yes.
Yes.
Thank you. Sorry, we now move off of that item and we move on to items for discussion. And the first is a pandemic update from Chris, and a presentation has been provided. Over to you, Chris.
Thank you, Chairman. I'll just share the presentation now to work through as I speak. And I'll move through this at a fair pace in order to then pick up questions afterwards, because I am aware that board members have already received updates from me as we've moved through. The presentation is in the pack as well for those who cannot see the screen. So I'm going to start off just with a general overview of the pandemic so far. And in general terms, we're about 20 weeks into the coronavirus pandemic in the UK, now onset roughly end of February in parts of the UK, early March for ourselves. And we've got to keep this in context. There's lots of learning for us, as has already been discussed. But we do have to remind ourselves that by far and away, this has been the biggest mobilisation and redeployment of activity in the NHS that any of us have had any experience of. And of course, it's not just with regard to the NHS, although at this NHS board, I'm clearly going to focus upon those components. There have been some absolutely phenomenal challenges that have arisen simply because of the infective nature of this challenge. And it's not just the challenges coming from infections, but it's actually the challenges coming from an infection that right at the very beginning we knew very little about, and which now we still don't know as much as we would like to know. It's worth reminding ourselves that the pandemic in the UK only started a short period of time after the very onset of the global pandemic in Wuhan. And so we went into this in the UK with a very low base of knowledge in terms of how coronavirus 19 would behave and how that would model through in terms of the demands it placed upon all of us. We've got to remind ourselves of that as we look through the actions that we've made within that learning exercise. It's true to say that there's been a significant impact upon each and every person in North Wales, not just us as healthcare professionals. And it's true that that is going to continue to be the case for a long time to come. And I think it's important to draw that out because you do sometimes hear now, as the numbers start to decrease, you do still now hear individuals thinking or expressing that perhaps this is over and we're going to quickly move into a post-coronavirus world. Unfortunately, that's highly unlikely. This is with us for a while. Just touching upon some of the clinical considerations then in terms of this journey. It's important and has been a challenge to consider that actually very many of those people who have proven to be positive with coronavirus and infective have actually been entirely asymptomatic. We always expected that some people would have coronavirus without symptoms, but we didn't expect those numbers to be as high as they actually are. I don't just mean that from a North Wales perspective, but that has been recognised across the UK and other countries. Our medical knowledge has developed considerably through the last 20 weeks, and the interventions and the success of those interventions has changed rapidly. We know much more about the best way of supporting people who require ventilation, for example. And board members will have seen the coverage a few weeks ago in terms of the role that some medications, and specifically dexamethasone steroid, has to play in patients who are unwell with coronavirus. And they're changing how we manage this and are requiring us to move in an agile way. With regard to the dexamethasone, it's important for board members to be aware that we contributed to the clinical trials looking at dexamethasone and roughly a dozen other coronavirus studies that we are engaged in as a health board. We do that willingly, but it often adds on top of what have already been very busy workloads for some of our clinical colleagues and our research teams who have added these studies into already busy portfolios. But we recognise it's the right thing to do, and it's important to celebrate the fact that we are research rich as an organisation. One of the clinical pieces of learning is in terms of oxygen requirements. Many people do require oxygen with coronavirus, but less than some of the original modelling suggested might be the case, and we've adapted to that as we've moved through. There have been some real testing and diagnostic challenges, and those continue. Throat swabbing for antigen remains the main way of diagnosing coronavirus. We have learnt across the UK that some individuals still test positive for many weeks on throat swabs after we know that they're clear of coronavirus, and that has introduced some complexities for us. We've discussed antibody testing in previous board meetings, and we've undertaken roughly 3,500 antibody tests in North Wales so far. I think it is still true to say that we're not absolutely clear yet what the most optimum role for antibody testing is. There is growing research in this area suggesting that maybe some people don't retain antibodies in the way that we had hoped. And so this is still an evolving area for us. Related to maintaining antibody levels and vaccination, lots and lots of interest at the moment in terms of when a vaccine will become available. You will have all seen on the national news in the last week or so lots of suggestions of a vaccine becoming available in October. It may be the case that a vaccine becomes available in October, but if it does, it will be small amounts, and we're still at present unclear what degree of protection that is going to afford individuals. And so it is still an area where considerable work is being undertaken. And until we have that vaccination programme, it is going to be difficult to plan for that. So we are working with a great number of uncertainties still. Moving on to our own data and looking at our testing data. We have so far over the course of the pandemic undertaken just over 100,000 antigen tests for 54,000 individuals in North Wales. Of those, just over 4,500 have tested positive, and where necessary have received treatment, although it's true to say that many individuals have been able to self-isolate and follow simple measures without hospitalisation or other medical involvement. At the moment, we're doing something between 1,000 and 1,500 tests per day. And what you'll see from the charts here, the blue chart clearly, the blue line on the top chart clearly shows how our testing numbers have rapidly increased over the course of the last 20 weeks. The bottom chart, the red line, shows that the numbers of diagnoses has fallen during that time. And what that tells us is we're testing more and more people and making fewer diagnoses. And that reflects the fact that we're coming through this first wave of the pandemic, and that numbers of circulating coronavirus disease are falling. And we're now in the order of certainly less than 5% of tests proving positive, which, going back to April, something in the order of 40% of our tests were proving positive. Looking at confirmed cases, this chart on the left, the stat chart, shows 4 different cohorts of individuals. Those that we're testing who are within care homes, those that we're testing because they're inpatients in hospital with coronavirus type symptoms, key workers, which includes health workers, but many other key workers as well. And then another category, which is where we group any that we're not able to clearly put into the first 3 categories. And what you'll see here is that those lines are reducing in North Wales. There are 2 spikes that you can see there, which relate to factory outbreaks that have been touched upon in the chair's introduction. And you'll see those also on the chart on the right side, which shows that this reduction is occurring in all of our local authority areas in North Wales, with 2 spikes there, one in Anglesey relating to the Two Sisters outbreak, and one in Wrexham, which related to the Rome food outbreak. In terms of our inpatient activity, in YG, in Bangor, the levels of inpatient numbers are low, and as of today, we have no inpatients with coronavirus in Ysbyty, Gwynedd. In Glenclwyd, the numbers have been quite high, but in recent weeks have fallen quite quickly. As of today, we have 5 individuals in Glenclwyd. We are currently experiencing a little bit of a heightened activity in the Wrexham area. That's both in the community and in hospital, and we're actively managing that. But it means that the inpatient numbers as you would expect in Wrexham, have not yet fallen to the same sort of numbers that we're seeing in Gogledd. Deaths are clearly of concern with any pandemic, and we have taken a very proactive view in terms of monitoring our death rates here in North Wales. There are lots of different ways of looking at death rates, and the metric that we follow mostly is the number of deaths that have been recorded by the Office of National Statistics as being due to or naming within the death certificate coronavirus. And if you look at those death certificates, then the numbers are continually falling now in North Wales. These are weekly reported data from the ONS, and that's both in the community and in our hospital settings. I want to touch upon hospital acquired infections. This is a really challenging environment. It's challenging for a number of reasons. Firstly, the incubation period for coronavirus is quite wide, and so it's very difficult to come up with a diagnostic a set of conditions that mean we can confidently say somebody acquired their coronavirus in hospital or didn't. It's also multifactorial. There are lots of reasons that impact upon how infections are passed or transmitted within hospital or any other closed setting. If we consider those, one of the biggest factors is actually how many people within that closed setting have got coronavirus in the first place, and for that reason, it's been pleasing to see that as our numbers of coronavirus in North Wales have steadily decreased in recent weeks, so too have our hospital acquired infection rates. We are concerned that in the last 2 weeks we have had a little bit of a spike in terms of data for hospital acquired infections, and we're proactively looking at that and addressing that. And there are a number of steps now that are in place to bring those numbers back down to the trend that we were previously experiencing. Part of that is how we now review hospital acquired infections. Right in the heat of a pandemic, when there are lots and lots of individuals with coronavirus or whichever infection it is, and lots of challenges upon the infrastructure and the stable delivery of care. Infection control generally is focused upon dealing with big outbreaks and dealing with ensuring that all staff are properly equipped with PPE and those kind of factors. As the numbers start to decrease, the appropriate course of action is to then start reviewing positive cases in a more detailed way, looking at learning opportunities, but also looking at any opportunities to reduce what are already decreasing hotspots to a point where we don't see hotspots at all. We now do those post-infection reviews, and we're seeking to do them in real time as opposed to close to real time. There is some progress to embed that, because it's a relatively recent period of time that the numbers have been low enough to do it. But our hospital sites are absolutely on board in undertaking those reviews. And so we're now in a position where we review that data, pick up any learning, and are able to intervene quickly. We follow national guidance in terms of the procedures that we use for our infection and prevention, and in recent weeks have reminded and supported our staff in terms of what the guidance expects in terms of personal protective equipment, in terms of all of the activities that can occur in a hospital, such as moving individuals for tests or moving individuals to different wards, that potentially can increase hospital transmission. We have clear standard operating procedures in place that cover the movement of staff and how we cohort individuals. And by cohorting, what I mean is moving individuals into grouping according to whether or not they have coronavirus, whether or not they definitely don't have coronavirus, or whether we're not sure, so that we're not mixing individuals who present a risk to others. We're moving staff and putting additional staff into those areas that are most pressured. We know that sites such as wards with coronavirus patients on are going to be pressured environments, but other pressured environments will arise from doing the post-infection reviews, and that will inform where we put those additional staff to make sure that we're able to provide the best effect. We're also progressing the implementation of testing all inpatients at the point of admission. Now, this is not a straightforward area. It might initially feel as if testing everybody coming into hospital is a straightforward thing to do and a good thing to do. We are of a view that it is the right way to move forward, but there are some real technical challenges when the number of circulating individuals with coronavirus falls within a community. Then the impact upon interpreting test results and dealing with false positives and false negatives becomes different to the interpretation when there is lots of coronavirus circulating around, and the value of some of that testing then becomes less clear. So we're working through what that means for us, but we do recognise that there is a role to play and are moving forward in implementing that on all of our sites. I'm just going to pick up temporary hospitals. We're all aware that these have been developed in keeping with the original UK pandemic scenarios. I'm pleased to say that we haven't needed to use our temporary hospitals for coronavirus activity so far. That is a positive because it means that the levels have not been that great. We are working with our partners now in terms of understanding what we need to do in making best use of temporary hospitals as we move forward. And that is a piece of work which we will progress over the course of the next few weeks and months to understand how it impacts upon winter. I'm going to quickly now just touch upon how we need to move forward. We're moving forward using short cycle planning now. It's important that we pick up some of the activity we've not previously been able to do, but that we're able to stop doing that activity quickly if a further surge occurs. It's important that we have alarm bells in terms of our analytics that tell us very quickly if activity is changing from the profile that we are working to. Of course, we have to be delivering safe care, so we're focused upon how we do that. And we need to understand that whilst we bring some of this activity back online, we're not necessarily going to be able to bring it all back online in all of the historic sites because we have to deliver it in a safe way, and that refers to the cohorting of patients that I've previously spoken about. A last couple of thoughts before I finish. We're all in this together. There's been some fantastic collaborative work. That work continues. It's absolutely important that we recognise that. It's absolutely important, though, to recognise that public engagement and the way that we behave as a society is just as important as anything else that we do. Public health guidance, we absolutely need to continue to get the message across all of our communities in North Wales that simple measures such as hand washing and social distancing remain as valid as they ever have and absolutely crucial. The way that we use services, we know that our emergency attendances have fallen in the early stages of the pandemic. That's because some individuals were using services inappropriately, and we recognise that. But we also recognise that there are some individuals who should have used services that haven't. Our services are open, they are safe, and individuals should present if they feel that there's a need to do so. Mental resilience has tested each and every one of us, some of us severely. That's going to alter the way that people access services and how we interact with people, the sensitivity that we will need to show to that, and the willingness that people have to discuss that. And finally, the last thing we need in the midst of a pandemic is a flu epidemic on top of that, which is made worse because people have not had their flu vaccination. Flu vaccination remains as valid as ever. The presentation of the flu vaccination programme this year will be a little bit different due to social distancing. But if ever there was a good reason to get your flu vaccination, then this year the pandemic must be it. On that basis, Chair, my presentation's finished.
No, thanks very much, Chris. I know Avion's got a question. Avion?
Yes, thank you. Thank you, Chris, for your fascinating presentation and also all your work and leadership over the last few months. As you said, the hospital-acquired infection is challenging, and PHW yesterday published a report saying that 11% of all cases were due to this. And as you mentioned, it has been a particular problem for us recently. Bearing in mind the significant level of asymptomatic people and the risk of a second spike this winter, should we not be considering introducing regular testing for our staff? After all, this is now being undertaken in all care homes in North Wales on a regular basis. And also, should we not ask all our staff to wear masks? After all, everyone should feel safe in our hospitals.
Okay, interesting points. So I referred to some of the challenges that testing all individuals coming into hospital have when numbers are low, where potentially you can find yourself in an environment where you get more false negatives, more false positives than actually true positives. And that's to do with the sensitivity of the testing when you're looking at low numbers rather than high numbers in the community. The same principles broadly apply to staff. All of that said, alongside testing patients, we're of a view that we should be using spare capacity to test asymptomatic staff as well. What we shouldn't be doing is using testing capacity at the expense of symptomatic individuals, but we shouldn't be allowing testing capacity to go unused either. So alongside testing more patients as they come into hospital, we will be testing more of our staff who are asymptomatic, as you say. And that's in keeping with the national testing strategy as well. In terms of face masks have a limited role, not a zero role. There is a value for individuals, even just in the physical appearance of a face mask. It reminds people not to touch their face. It reminds people that they have to follow other safe practices from an infection prevention perspective. And on that basis, are encouraging visitors to our sites to use face masks if they are willing to do so.
Avion, does that cover your question?
Yes, to an extent. I mean, I know that care home staff have been tested on a weekly basis, and I think that's now going to be reducing to a monthly basis. So there will be a bit more capacity in the system. But the fact, as you mentioned in your presentation, that so many people, including our staff, are asymptomatic, will cause concern. And as many as our staff as possible, I hope, will be tested. And I think the question of masks is a hot political issue at the moment, obviously, particularly in England. But I think if we're going to be asking our patients and visitors to be wearing masks in our hospitals, the same should apply to our staff as well, to give everyone reassurance.
So just picking up the staff point, I'll probably hand over to Jill if that's okay in terms of masks. But picking up the staff point, absolutely agree. As I've said, that if there is spare capacity, that should be used. What's important, I think, is that we try and target that as best as possible, so that we're focusing upon frontline areas where we know that the greatest exposure to coronavirus exists. In that way, we're more likely to get positive results, and the significance of those compared to false positive results will be greater. And that's something that myself, Jill and David and other colleagues are currently working through.
So just in that regard, so there is work going on between you and your colleagues. There has been a discussion this week, isn't there, about the wearing of face masks, and we know that our staff would support that, certainly in terms of the sites that I visited in the last week, and you would have done the same, I feel sure. So Jill, do you want to come in from an acute perspective, and then Sue Green, if there's anything you want to add from a staff perspective in particular, let's go there next. So Jill first.
So if I may pick up on the masks first, Chairman, and can I say face coverings as well as masks? We know that staff and public have actually actively requested some of this in the public areas, where some of the public areas in our corridors and more public areas in our hospital sites, social distancing is really difficult to maintain. So yes, we are actively encouraging now staff and public to use face coverings where they feel able to do so. In terms of the additional work, where we are seeing outbreaks on wards, we are testing all the patients on those wards. We are putting additional staff on those wards because some of our patients find it really difficult to socially distance. So we are supporting that with extra staff to be able to support patients who are potentially confused, disorientated, who may wish to go into areas where we would prefer that they didn't go too close to other patients. We're also testing staff in those areas with the support of our HR colleagues. And I think that is important because transmission can be via staff to staff member, as well as from patient to patient. And again, we are supplying the PPE to support the transmission. So there's a number of things that we're putting in place. I will say that our staff are really keen to pick up this challenge. They're working incredibly hard. The cohorting is taking place. We are doing more and more testing. We now know the laboratories have the capacity to be able to support us with the patients being tested as they come into hospitals as emergencies as opposed to elective. And I think it's important we take up that opportunity. So that is taking place now. So I didn't know whether you want to pick up any more from an HR perspective on the testing of staff.
Thank you. I think one of the things that I would want to add to all of those things is around the confidence levels and the psychological health and well-being of both our patients, visitors, and staff as well, and particularly noting that we will have, during the August period and September period, members of staff who have been shielding, who are clinically extremely vulnerable, returning to work where they undertake duties that require them to return to work, particularly, for example, our medical and nursing and therapies colleagues. We will be absolutely building in testing as an option as part of our risk assessment process for those returning members of staff. And we will be absolutely clear that those members of staff cannot return back to work until we've undertaken a really robust risk assessment. That also applies to the vulnerable and protected characteristic groups that we we have within the workforce. So I think that you know, there are many factors that lead us to determine whether we should be undertaking targeted but routine testing, and whether we should be deploying face coverings as part of a PPE requirement. So I think it is very much thinking about this from a risk-based point of view, very similar to the decisions around care homes, which was very much risk-based, looking at the prevalence of the virus. We need to be adopting the same approach, and that's something that we're working very closely with our staff and trade union colleagues, as well as our clinical colleagues on.
Thanks, Sue. There are a number who wanted to ask questions, but which I'll come to in a moment. So, Jill, just to note that I have asked for a review to be carried out of the in-hospital transmission. So there's work going on, isn't there, around moving forward, but we're also examining what we might learn from the past as well at the moment.
Yes, you have, Chairman. We will be taking that forward. I think it's also important to note that some of the points picked up as part of the review, we're already learning those lessons, so we're not waiting for the completion of the review to implement changes where we feel it's appropriate. And some of the things that we've mentioned clearly come from that, not least the way that we are collating data and presenting it to the executive team.
Okay, then can I just ask, in terms of the East and Wrexham, Myler in particular, where there has been an increase, Teresa, I don't know what you can say if you're on the line about testing in the East to support the work that's been described around in-hospital transmission.
Thank you, Chairman. So you'll be aware that we're involved in the OCT meetings across Wales, of North Wales for this one. So it's the Outbreak Control Team meeting. We met yesterday, and as part of that, of course, we agree control measures going forward. So we reflected on the small increase in cases, but we are watching those cases across the East all the time as part of our surveillance. And as normal, we'll be looking at the control measures along with partners going forward. So actions are underway. They've been underway throughout the OCT process, and maybe changing our focus a little just now. So again, we'll be looking at our testing approaches in Wrexham area.
Thanks, Teresa. Okay, so I'll come to questions now. So Michael Rees is first. Michael.
Thank you, Chair. What I wanted to ask is that we know that COVID-19 is a multi-system disease, not just a respiratory disease, and our testing has in the past been hampered by restricting the number of symptoms that we test for. At the very least, I think we need to make sure that staff are aware of the spread of symptoms. The American CDC lists 11, and that number is growing for testing. The other thing that Chris referred to was false positives, but actually the more worrying aspect of testing is false negatives, which can be quite high. So having this increased awareness of the number of false negative tests and the spread of symptoms, I think would be very helpful. The other thing we've learned, I think, over the last few months is that if you test simply by taking one swab in the mouth, then you're going to get more negative tests than if you combine mouth and nose swabbing, so that's helpful. My question really relates to what Sue said, and that is the understanding that we have a large number of vulnerable individuals. And I'm not entirely sure from the presentation how much we are recognizing that the virus discriminates quite badly to certain groups in society, to ethnic minorities and older people and people with vulnerable conditions. And how we should focus testing to take care of those issues.
So, Chris or Jill, do you want to come in?
Answer that one. It fits in with the equality portfolio. As you're involved in a lot of the work, Michael, I think it's a really valid question, and a really valid question to draw out in a public setting. I mean, very clearly, we have been working in a very focused way, particularly with our BAME colleagues. You'll be aware that we have been undertaking individual risk assessments, and to make absolutely sure that we can assure the board of compliance with risk assessments. They are being submitted to to my team. They are then being reviewed by the health and safety team, and we have started to pull together. We already have a BAME network group, but we've started to pull together a wider representation on that, really advising on the quality of the risk assessments undertaken. We've also started to revise those risk assessments following lessons learned from a number of investigations that we've undertaken, particularly building in the impact of cultural impact on behaviours and the likelihood of wanting to be compliant and not making a fuss, etc., for a number of communities, as well as residential impact and multi-household contact. We have broadened that risk assessment approach to the wider vulnerable groups, and we've had a number of meetings, in fact this week, around the measures that we are going to need to take to make sure that those other vulnerable groups, plus those who are shielding, have robust risk assessments underneath them. But most importantly, that the actions that are identified as part of those risk assessments are carried through and are visible, both from a confidence level and a psychological well-being of the individuals, but also from a physical health and safety point of view. So I think that's what I was referring to a little bit earlier on. We've got our equality network and our strategic equality group are very, very heavily hooked into our health and safety team and to the wider staff engagement to make absolutely sure that we're kind of equality impact assessing everything that we're doing and every decision that we're taking. I think that, and again I referenced it a little bit earlier, that will link into the targeted testing and screening from an antigen point of view, and I think will build into the testing strategy around antibody testing too.
So Chris or Jill, thanks Sue, do you want to comment on the CDC symptoms and growing list, and also the false negative point that Michael raised? Can one of you come in?
Yeah, I'm happy to. Absolutely agree with you, Michael. From trying to establish from a symptom basis who to test, there are a huge range of symptoms, and it's not just those individuals with upper respiratory tract infections. And I think it's fair to say that our clinical teams across have been broad in their interpretation of individuals to test as being potentially suffering from coronavirus, but we still see individuals who are asymptomatic or who have a slightly unusual mix of symptoms, and moving to a position where we're able to test everybody is of course helpful with regard to that. Equally, I agree with the comment that you made in terms of false negatives. I didn't want to get into a tutorial about false positives, false negatives, and the benefit of screening, so I touched upon it briefly, but you make a very valid point.
Okay, thanks, Chris. Lucy, I believe you have a question.
Diolch, Chair. It's more of a comment, a general comment, really. Firstly, I just wanted to acknowledge the huge contribution that the public and our partners have made during this time. As the Chair mentioned in his introduction, the Health Board is facing a significant challenge to restart services in a safe way, and this can only be done with everyone's continued support. Some of the services have changed the way in which they've delivered in response to the pandemic. And the ongoing risk, as Chris has referred to. But some patients are understandably very nervous about coming into practices and our hospitals as well. And the in-hospital transmissions that we've just discussed will undoubtedly add to their concern in relation to that. But what we don't want happening is harm occurring as a result of people not seeking help either. So that there is a balance to achieve. And so the recent additional controls that have been put in place to try and reduce the risk, which has been discussed and we will be considering again at QSE committee next week, are very welcome. But I think the review of the in-hospital transmissions as well will be helpful to learn from. And I know there has already been actions taken in response to that to try and reduce the risk. Thank you, Chair.
Okay, thanks, Lucy. Helen, I'm going to move on to you.
Okay, great, thanks. Thanks, Chair. I want to ask a question actually about going back to the beginning of the presentation really by Chris, which was excellent, and thank you for all your leadership and the leadership of the people behind you, because I know it's been a mobilisation within BIPBC as well. You talk about, you know, it's been the biggest mobilisation and redeployment of activity in the NHS in modern times, and that it's not yet over, so that the challenges of the pandemic are still with us. So we're all acutely aware of that. One of those challenges is that we're dealing with a relatively unknown virus, and the trend data and intelligence that we have is rapidly changing, rapidly moving. So my question is around, and I appreciate you may not you know, sort of feel you have the answers today, but it's around what you think, what your data mining and sort of trend insight analysis is showing based on international, national, as well as local kind of intelligence around the nature of, as it were, what the trends are on a potential second wave, and what the nature of that second wave might look like in the context of North Wales. Yeah, and I think that it would be really useful to hear about some of that, what we're picking up and learning from internationally about the trends there, as well as what's happening elsewhere in other areas, because it appears as if what the nature of the second wave might be very much around local outbreaks. And then I guess my question is around sort of the mobilisation that we do around that with our partners, because this is not just a mass redeployment of NHS activity, but it absolutely needs that collaborative approach with the partners, doesn't it? So I appreciate I've kind of gone around the houses a bit, but essentially it's the question of what is the data within its limits telling us about the likelihood of a second wave and the nature of it, if you like.
Okay, thank you, Helen. Okay, a second wave is almost certain. We would anticipate that. Much of the reduction that has occurred because of a lockdown in terms of our individual activities within society, and as we try to return to some degree of normality, which is absolutely crucial from an economic perspective, as you're aware, and also from a mental health and resilience perspective, we will likely see some rise in transmission, which will then potentially feed into second phases. You're absolutely right that they may be more sporadic in terms of the locality, and we're mindful of the fact that our response may need to be on a more granular level than it has been so far. There are epidemiologists who know far more than me about this in Public Health Wales and across the UK, who are doing all sorts of data analysis using lived experience in terms of the first wave, but also the experiences across the world. We're using that information, and we're very grateful for it, and we do our own local analyses on top of that too. So we are very reliant upon that analytical stuff. We hold it in high regard, but we don't consider it to be a black and white route map. We already know from the modelling data that the first wave did not quite work in the way that the epidemiologists thought it would. So we're using the data to try and understand what the size of the potential risk would be, and to take a risk balanced approach. We're looking at how we deliver that on a local basis should the need arise, and I referred to the short cycle planning that we're doing now, so that we can quickly turn things off and move resources. And just to pick up your final point, we do all of this in partnership. Absolutely crucial. We cannot do this if we're not going to do it with partners across North Wales.
Could I just ask one follow up on it, Chris, in terms of the partnership working? And I guess it's about our strategy for engaging the public, and whether we think there's more that we can do there, because you made the point very powerfully in the presentation that actually we're hugely dependent on the public working with us and engaging with us on.
Yeah, thank you. Thank you, Helen. We're very clear in the recovery group that communication and engagement moving forward is going to be absolutely critical, and there's a specific piece of work within that group.
Okay, thanks, Chris. Thanks, Helen. Medwyn, I'll turn to you last for the final question, and I'm going to move us on.
Good. Thank you, Chair, and thanks, Chris, for that very comprehensive presentation, and thank you for all your hard work, of course, during this challenging time for all of us. You mentioned flu at the end of the presentation, and of course, what may compound the current situation regarding the pandemic is an epidemic, which is, if not dealt with appropriately, will cause real problems for the NHS. The plan, which we're about to discuss later, talks about flu immunisation programme this year and the challenges ahead that we now face. However, looking back to the December 2019 IQPR summary, it stated that although our performance was the best in Wales for the flu immunisation programme then, it went on to say that every effort was being made to improve further towards delivery of the targets, despite some issues initially experienced with the distribution of the vaccines. So given the seriousness of influenza itself and where we are now with within this pandemic and the greater demand for those who are eligible for the vaccine, how confident are we that we will be able to see an increase in patient accessibility to the flu vaccine? And of course, the issue also goes hand in hand with the delivery of the COVID-19 vaccine if and when one becomes available.
Okay, thanks, Medwyn. Okay, so we are traditionally reasonably good in terms of our flu vaccination in North Wales, as you've referred to. We did well again last year, but last year's season was particularly challenging because of a change in approach to the different numbers of vaccines that were available and some supply chain issues right at the very beginning. And I have to say, with plenty of years of experience of running flu campaigns out in primary care, those first few weeks of a flu campaign are really, it's a really nervous time, because that's when your greatest number of individuals wanting vaccination come in. You're wanting to get as much of the community vaccinated as early as possible, but you're so dependent upon the companies having the supply chain and that they haven't had any technical issues in terms of providing the vaccinations. It normally comes good as those weeks move through, and I can't think of a single season where the numbers of flu vaccinations ordered haven't then been adequately supplied. Most primary care providers overorder on the basis that they can return and refund unused supply. So already built within previous numbers has been some capacity to be able to deal with a greater influx of individuals. On top of that, we coordinate at health board basis our response, and we've taken into account there the potential of an increased interest this year in flu vaccination, and I'm aware that above a local level, at national level, Welsh Government have also done the same. So in conclusion, bringing all of those together, I'm reasonably confident that we will be able to match any demand for flu vaccination this year. We absolutely must chase down everybody who might be eligible for flu vaccination and is willing to have one because of the reasons that you've just referred to. And the programme will look a little bit different this year because of social distancing, but we'll do it.
Okay, so I'm going to sum up now and move us on. So first thing I want to say is you quite properly referenced, Chris, the collaborative working that's gone on with our partners, which has been impressive and continues both in terms of the BIPBC programme, but also wider. So, for example, we shared the Q2 plan with the Regional Leadership Board last week because we're keen to ensure that our plan integrates with their plans and we move forward together. I though want to comment on the cohesiveness and the partnership working that we've seen internally. That within the executive team has been impressive. It's also been impressive in terms of our area and hospital teams, for example, in terms of putting the temporary hospitals in place. But more so through the visits that I've been carrying out this week again, the flexibility and sense of team that our frontline staff in particular has displayed, be they clinicians, nursing staff, porters in our hospitals, or no matter where they are, and their flexibility to do other jobs in time of crisis has been truly impressive, and we ought not to lose our recognition of that fact in terms of what's gone on and what continues to go on. I think finally, Chris, so your final thoughts are the ones that I think we ought to echo as a board, and that is, we want the public to continue to follow the guidance. That will help them, that will help us. That we want our public to use our services, including the emergency departments, but we want them to do that appropriately. So to ensure that there are other routes to securing access to health provision, be that through your GP, be that through GP out of hours, and so on and so forth. But we don't want people to stop coming forward, because that will be of concern to us about their own condition and health. And we'll come on to the restart of elective services a bit later when we talk about performance in the Q2 plan. But also your final points around mental health. We are considering our mental health provision, what else we can do to support people in our communities. And coming on to winter preparedness, we are already preparing. We are already preparing for a flu pandemic and the necessary plans being put in place. So we are keen to ensure with our partners that we're ready for what might come in the winter. And I wouldn't want anybody to think that the planning hasn't already started. So with that, we'll stop on that particular item. Thanks, Chris and team, for the presentation. So without further ado, Teresa, we'll move on to the TTP update. Thank you.
Diolch yn iawn, Cadeirydd. Diweddariad byr fydd hwn ar y cynllun profi orlaen a diogelu yma yng Gogledd Cymru. Thank you for the opportunity to speak to the Test, Trace and Protect programme for us here in North Wales. I've updated board colleagues at a number of meetings now. But actually, I was reflecting that this is the first time we've discussed TTP at public board. And I think that tells us something about the pace of this programme, that we've gone from not having it to setting it up to having actually a good team undertaking this work across the region, and that team right across the region with all partners, I have to say, a real partnership approach. So in the paperwork, I've just reminded colleagues why we're undertaking this work, because it is really most timely that we discuss this today as we're in easement. Some people are considering perhaps some breaks, and certainly more cars on the roads than ever this week on the A55 certainly. And of course, the TTP programme is about us being able to live as normal a life as possible, especially while we await the vaccine. And Chris has stolen my thunder because we have a key meeting this afternoon. Work is underway on the planning for the vaccine. I, like Chris, believe it will come in small amounts. So until then, we really must have a good TTP programme. And even when we start vaccinating, we'll still need TTP to support us. I've briefly mentioned in the paper the three elements of TTP. Testing is something we've discussed at board previously, because we've been testing various groups at various times, but it does feel now that we're getting to quite an industrial scale of testing and an area of business which we haven't done at that scale normally within the health board. We're tracing, which is the second T, contact tracing people, and that's for those people who have been in close contact with someone who tests positive. That will change going into the autumn, because we expect to be testing on symptoms, which is actually how the programme was set up. But I believe that will come in the autumn months. We're not quite there yet, giving us a chance as a programme to develop. And then the third element of TTP is Protect, and that's about wrapping around, as I call it, some of the most vulnerable or at risk from the virus, and also supporting those who need to go into self-isolation, whether because of financial issues or other issues. we need to make sure that we're safely looking after each other. So we started the programme on the 1st of June. We had about two and a half weeks to set it up. The region came together, and I echo everyone's comments. They're working brilliantly across the patch. From a governance perspective, the line of reporting and accountability is through SPPH. So I'll be taking some more detail of the programme, the governance, to the next SPPH meeting for us in the board. But of course, I also provide updates at the RCG, which Chris mentioned a little while ago, the Recovery Coordination Group chaired by Mr Colin Everett from Flintshire County Council on our behalf in the region. From a Welsh Government perspective, since we've started, I think the first few weeks were challenging. We didn't have a national IT system. We had to create our own. We were bringing together deployed colleagues at a local level, at a regional level, and I know national were also challenged. But things are now settling, and a new Chief Operations Officer has been brought in to Welsh Government, Mr Jeremy Griffiths, and actually he's really helped us move forward in terms of some standardisation across Wales, but also helping us unlock those final few challenges that we have in maybe all three areas of the TTP programme. I won't dwell too much on testing. You know about this work. By now, when I look at the Welsh numbers and us in North Wales, probably 50% of our tests are currently probably going over to Manchester through either home testing kits or the tests being undertaken in the D-side or Llandudno mass testing site. That's allowing capacity for some of those urgent tests that we need undertaken here in North Wales. And I have to say, I often talk to you about turnaround times, the time between the requesting and the actual reporting. And while there is variability, the good news is we are seeing improvements. There is a challenge ahead, I think. I believe we will be asked to work to a 24-hour turnaround, and I think that will challenge us. But we do have an operational colleague supporting us on mapping all elements and trying to streamline all those elements within our control. But of course, again, this is a partnership activity with Public Health Wales. There is a new dashboard or a prototype dashboard on turnaround times, and I'm sure that will be made public once it is more robust. It is a bit fragile at the moment when you use it on the IT, but I'm sure that will be helpful to board members, because I know colleagues have asked in the past, Avion, I know you've asked many a time on turnaround times, so that feels that we're getting to a good place. The laboratory capacity you mentioned at the beginning, Chair, good news is they seem to be up to 1,400 this week as capacity, and that is important, because as we test more in the hospital and as I need more people tested in the community, we need the capacity here in North Wales. Antibody testing is also described as part of the testing strategy. And while we're not using it necessarily as part of our TTP arrangements, it is key. And we're still learning about immunity through that programme. And I have 3,641 tests mentioned here, that I can see Adrian's beaten me to it, and we're over 5,000 now, which is great news for us. So thank you again to the team there, which is really newly established, but again, challenges for all in terms of thinking through the scale going forward. I expect for board members, the most interest is in contact tracing. So much of the work is done at local level through teams, which are within each of the local authorities. And I have to say, with EHO colleague support from local authorities, the environmental health officers, that work is progressing well. We now have a national IT system. People are settling into that role. And at the regional cell level, where the more complex cases are discussed, then certainly that's bedding in. But I have to say, we've had a number of cases through that system. It is quite challenged in the regional cell in terms of activity, much more than anticipated in the model we received to work with. In terms of contact tracing, I've given you some of the numbers within the paper just to give you a feel of the scale. And soon, and as of this week, I should be able to start providing reports to board members, to the performance team on our activity. So we've now been enabled to use the national system to develop reports which we can use locally, and also for us to be scrutinised by yourselves, by partners and by Welsh Government in terms of are we really hitting the actions that we need. We need contact tracing at pace for this to work well. We need testing in a timely manner. So some of that's coming through the system, and I'm hoping to share some of that with the SPPH committee very soon. Good news is, as Chris has mentioned, overall the numbers have gone down, but we are watching carefully some areas as we see increases in cases. And I mentioned at the back of the paper the 2 outbreaks. The Anglesey situation, certainly within the factory, but I'm very careful to use the term the outbreak associated with Rowan Foods. And certainly at the moment, I'm keeping an eye on general community transmission. And we mentioned a little earlier about the East in terms of our own estate here within BCUHB, in terms of understanding our whole picture of community transmission. And that, of course, is of interest to outbreak control team members as well. So we'll work collectively on partners going forward. Good news is that the funding envelope from Welsh Government has been confirmed, and so we're working with local authorities on that, in that there's a sharing between the regional cell requirements and the local cell. The good news is we should get to an employed model of staff, more sustainability in our staffing, which means that we can really tailor this to our local needs and to the regional needs. So really do, I'm grateful to Welsh Government for that funding envelope being agreed so quickly. Data sharing is moving well. Also, a significant amount of work has been undertaken at an all Wales level and also here in North Wales. So we're in the final stages of that work as well. And I'm certainly leading some discussions to understand the regional and national interface. The model gives us some clarity, which was in the paperwork initially, but teasing that through for the practical arrangements is key for us as we go into the winter months. And then finally, on the protect element, the third part of the programme, I think we've had 4 national meetings now. Much of the focus has been around the wraparound, the language issues, making sure that we do protect our most vulnerable, being a focus on learning from the outbreaks that we've been through or are going through, perhaps I should say. And here locally, I'm looking to pull together a mini workshop just so that we build on the assets that we have. The rest of the paper deals a little with the programme management. I've mentioned the accountability through SPPH, but I've also put in the risk ratings that we've got, and they've changed a little, I'm glad to say, since this paper was written. So I would say as this week, technology feels more green. Finance, I've already mentioned, is green. Data and reporting, still red because we haven't got the final agreement, and you'll have heard the news on England this week. So an area of much scrutiny, we need to get there. So things are moving forward well, and my plan at the moment is to now move from a regional planning group to a regional oversight model to make sure that we move the work forward. So in summary, I would say that the work is progressing well. Still lots of challenges. We're learning about the IT system, and we're also trying to work better to think, how do we wrap around our most vulnerable? And I expect we have a challenge now ahead for the coming months with a number of tourists who will come into North Wales. And yesterday I had some cross-border discussions as well, which I think will support us going forward to make sure everyone is clear on their roles and responsibilities, given the number of people travelling north, across North Wales and with border areas. So I'll end there, if I may, Chair, and take questions. Diolch yn fawr.
Diolch yn fawr iawn. First question from Lucy.
Thank you, Chair. Diolch, Teresa, for that. Could you just very briefly explain the selection process for those who've been selected for testing for antibodies other than the teachers? Because that places the 7% positive results into context. And also, do we know yet what having antibodies actually means? You know, what the level of confidence that this means the individual is protected, if we do at all know that? Thank you.
I'll take your second question first, Lucy, if I may. So no, we don't know enough yet about the immunity that's conferred from the antibody status. And actually much of the work that has happened so far is about learning and understanding that element. So that then limits at the moment some of our work or our planning work based on antibody testing. But the new testing strategy, which came out from Welsh Government last week, certainly is supportive of the work. And Adrian kindly leads on the work for us within the Health Board. And so we are trying to pull together a plan now of how we as a region wish to use antibody testing while some of that learning is still being undertaken. So then if I go to your first question, Lucy, very valid question. We had a CMO letter in terms of those that we should antibody test. The classroom staff who had been involved in the educational hubs was a direct ask, and there was an ask for us to work on our health and social and healthcare staff within the health board. And actually, the plan from our team was to work with those in the high risk areas initially. Since then, of course, we've continued to test, and the group have been revisiting that work this week to support that and to take us forward, as we know that there are requirements in primary care and in other parts of the health board which maybe aren't so visible and close to maybe the secondary care teams. I can see Adrian's willing to come in as well, kindly, who's been leading this programme.
Adrian?
Yeah. Thank you, Chair. Thank you, Lucy, for the question. I think Teresa, to be honest, has covered it, as in we've followed the guidance and the letters from the CMO. Started off with red areas within secondary care, recognising as well, and working with primary care, because there are obviously red GP practices. We're also working with WAST at the moment, as a very close partners, working interdependently with our teams in all aspects. So we're in conversation with them, and we're awaiting more guidance on, I guess, the next stages of this. Some of it is included in the strategy, and we're getting some numbers around those. You're right, Lucy. I think the positivity rate has started to increase. I guess we might have expected this. We didn't know what the positivity rate would be for classroom staff, but always thought it would be, I guess, higher for staff who've been working in healthcare environments. So it has, as those are measured together, it has shown an increase in the overall positive number of tests, or percentage of tests that have come back.
Okay, thanks, Adrian. I know we've got a number of questions. I also know we are now running behind the agenda. I don't cry the discussion that we've had because they've been important topics, but can people keep the questions and answers as succinct as possible, please? So without further ado, Cheryl, I believe you've got a question.
Yes, thank you very much, Chair. Teresa, first of all, I'd really like to thank you. I know from our very regular meetings the massive amount of work you and your team have done and how hard you've worked in such a short time. And for that, again, I really thank you. My question has two parts. The first part is, I hope you can answer, do you know why Public Health Wales changed their decision to temporarily place the Gwent machine, Starlet, in North Wales, which would have increased our testing capacity? Do we know why that didn't happen? And the second part is, how long does it take for the machines to actually be up and running? As the Nimbus machine, which was installed in Bangor on the 13th of June, which will increase our capacity by 288 per day, but it still isn't operational. This will also be relevant when the expected Wrexham machine arrives in 2 weeks. I'm worried about the delays. So thank you for that.
Thank you, Cheryl. Thank you for your kind words. In terms of Public Health Wales, the machine that didn't come to North Wales, I don't have an explanation, bar that I've heard another health board nabbed it. So clearly need to work with partners to understand that a little more. In my perspective at the moment, I'm just keen that we do get sufficient testing capacity in North Wales. The Lighthouse Labs, I have to say, has helped us from that perspective, and their turnaround is good. So in those ongoing discussions with Public Health Wales to understand, so that we get a fair share of those thousands of tests that are available across Wales. I'll keep you posted, Cheryl and board, on that. In terms of the setup, it has been normally around a week to get most of those up and running. And I will check back, Cheryl, because my understanding was that some of that capacity was now available to us, but that may have just happened in the last few days, Cheryl. So I'll get you a formal update if I may, and I'll share that with all the board members.
Thank you very much, Teresa.
I guess we ought to be concerned, Teresa, that the device has been taken away from us without understanding why that is. So I think we do deserve an explanation. And moreover, you'll know as well as I do that staff and members of the public are concerned around turnaround times in respect of testing. So how does that feel to you at the moment in terms of where we are now, particularly given we've spoken about testing for in-hospital transmission, and where should we, I'll use the word delicately, be pushing, if need be, to secure increased capacity?
Thank you. The microbiology staff who work for Public Health Wales but sited within our labs and support us every day, in all fairness, have been working with IPC colleagues and ourselves in the testing group to make sure that we're prioritising tests as need be. And as mentioned earlier, we're in a good place at the moment in terms of testing our hospital patients, so no huge concern there. But for me, having worked through 2 large incidents now, very recently in North Wales, and in all fairness, additional runs were put on through the evening sessions by Public Health Wales, I am keen to understand the capacity going forward. So I think as a board that perhaps after today, maybe we should write to Public Health Wales. If you and the Chief Executive were content, I think that would be a helpful thing to do, to get some clear timelines, because the timelines have not necessarily been clear, and that's partly because of the challenges in terms of the kits and the reagents. You can imagine everyone wanting to use the technical equipment, so we're probably in a queue. But I do believe that with the size of our population, we should have access to more. The TTP colleagues in Welsh Government are aware of the situation. I've certainly made that clear, and that will be part of our weekly discussions now with the Chief Operating Officer of TTP. So I think the prioritisation there of tests is in place. We have capacity at the moment. My worry is if surges in any way because of incidents, outbreaks, we need that in place. I personally am concerned that we have tests going North Wales, and sometimes I also have specimens going to South Wales. That can be challenging when we have issues with phone numbers or emails not being quite correct. And then in terms of understanding where the delays are. And of course, we've got the care home element as well, and we do not wish to have delays there when we know there are positives. We need to keep moving it through. So perhaps if colleagues were able, a letter from the board would be helpful from yourselves. Thank you.
Okay, Chair, so let's aim to get a letter off then by close tomorrow, can we?
Yes, okay.
I know you've been monitoring the situation, driving forward with a number of tests and turnarounds, but let's, if we've still got concerns, let's pick that up as soon as we can.
Thank you.
Okay, thank you. Helen, I believe you've got a question.
Thank you, Chair. And in the interest of being brief, I'm not going to ask the question around that I was going to ask around local outbreaks, because I think that Chris partially covered it in the top end, and we can pick it up in SPPH, I think, in August. So the question I have really is around the programme's been in place since 1st of June. You've given us assurance around the effectiveness of the multi-agency response. My feeling, and a lot of the feedback that I'm getting from colleagues and members of the public, is that in effect there's a 4th pillar of test, trace, protect, and it's engage, isn't it? So my question is about how confident we are that we've got the right stakeholders around the table, and that the and what status is the engagement strategy at, and are we confident that we've fully engaged the breadth of the voluntary community social enterprise sector, the breadth of the local business sector, and also the kind of grassroots community groups, and you know, in many ways, most important of all, direct channels and engagement with the public. So that's my question.
Thank you, Helen. A good question. And you'll see from the paper that I submitted, I've got communications and public engagement as a red, and you know, I'll be honest about that. We've been hands-on since 1st of June, just trying to get a programme which is safe, robust, works, making sure we don't miss any cases. So that's been our main challenge and focus. But we're at that stage where we need to communicate, and we've had anecdotal feedback through 2 Welsh Government feedbacks that people still don't fully understand TTP and what it means to them. So this is an area we need to work on. So the mini workshop on Protect is key for me. I think that's part of the messaging. Through the incident work, we are certainly working with the local engagement teams, the voluntary councils, through community networks and leaders. So I think we're getting better at that, but I do think we need to be more proactive. and pull that together as a full engagement plan. And I believe there's some new assets coming through, Helen, which might be better than maybe what we've been using so far. So there's a whole host of work that we need to do. And I would add that my lead for testing, and my thanks to Glyn, who's just kept going with testing, he would be my natural link to you in the voluntary councils, etc. So as I hopefully find replacements for Glyn, my aim is that he'll be able to move into the space so that we have better communications from September onwards. But we are also using the local networks, and part of having the local level of TTP is that they know where to signpost within their local structures for those vulnerable people who are on the phone who just maybe need signposting. And I think social prescribing can come into its own supporting this. So thank you for the question, Helen. We need to do better.
Could I just make one comment that it's also about engaging the local business community, isn't it? So I would really like to see us embracing, Federation, small business and all those kind of business groups, because employers have a key role in getting this message out too, don't they?
And if I may, Chair, and Helen, come back on that one, I'm aware of some Welsh Government work where they've made the links already through that. So we need to now pick up our part, but some of that work has started through Welsh Government to support us. So thank you, Helen. That will be another task for us going forward.
Thank you.
Okay, so finally on this item, Avian, I think you've got a question too.
Yes, well, sylw sgynna I, Mr Cadeirydd, a just gair byr o ddiolch yn fawr iawn I Teresa i'r tîm am ei gwaith proffesiynol iawn yn Llangefni. Mi oedd y mater o bryder iawn ar yr ynys, ond mi ar i'r sefyllfa droi allan lot gwell nag o'n i'n poeni amdano. So felly diolch I chi a'r tîm, a diolch hefyd i'r gwaith gan Cyngor Ynys Môn. Just wanted to thank you very much indeed, Teresa, for your excellent work regarding the outbreak in Llangefni. It was a matter of great concern on the island, but you managed to contain the situation. And I wanted to thank as well also the professional work for the team in Anglesey Council. Obviously, they managed to contain the outbreak, and hence the very low figures that we have in Ysbyty Gwynedd at the moment. Diolch yn fawr iawn.
Diolch yn fawr iawn. Diolch chi am y geiriau caredig, ac gwaith tîm go iawn. It really is a partnership effort. Thank you, Avian. Diolch yn fawr iawn I chi.
Okay, so thanks very much, Teresa, for that comprehensive update and for all the work that's been done, that's been echoed by colleagues. So we've agreed the letter will go out by close tomorrow. Your assistance with that will be helpful. I just want to make the point too, Teresa, that this update to this board is important because ultimately governance is via the board for CTP and we're accountable for it. So it is pleasing to see this update, and as you know that we're asking for regular reports on the programme as we move forward. So thanks for meeting that request and requirement. So I'm going to move us on. So we're now on to the Q1 plan, Mark. I'm going to assume that people have read this plan as ever, so take it as read. And before we go into any detail, I just want to make the point that as Chair of Finance Performance Committee, I've already called for a more detailed update on a number of items in the document, which I'm sure you'll be able to reflect in your update, Mark, in terms of stroke, eye care, essential services startup, and also the pathways in some terms of some of our specialties. So without further ado, Mark, over to you.
Okay, thank you, Chairman. So we are now planning on a quarterly basis as a health board, and this has replaced our normal annual planning approach. This is an example of the kind of short cycle planning that Chris referred to in his presentation earlier on, and we submitted our Q1 plan as a health board towards the end of May, and that was in line with Welsh Government guidance. This report summarises our status against the actions in that plan at the end of June, and obviously that is at the end of the first quarter in this financial year. The process of compiling the report is by now well established. It's self-assessment by the lead executive director, and when all those scores and the report has been pulled together, it's then reviewed and approved by the executive team, and this report has gone through that process. It has received prior scrutiny not only by the executive team but also by Finance and Performance Committee, Mark, as you've referenced. and the F&P committee requested written updates on a spot check basis on the 3 areas that you highlighted in your introduction. So we'll be reporting those updates back to the next Finance and Performance Committee. I'm going to hand back to you, Mark, and I or my colleagues will be happy to deal with any questions on this report. Thank you.
Okay, thank you, Mark. Lucy first.
Thank you, Chair. Having a look at the plan, Mark, I just wonder if there's some amber actions in a couple of areas, particularly page 7, which includes 2 amber actions relating to stroke rehabilitation services. And on page 12, it refers to the harm review of waiting lists. Could you just provide some more detail on that, please? In particular, stroke rehabilitation services I'm concerned about, because that's been identified as an essential service, and demand may increase actually as a result of COVID, as we've discussed previously. Thank you.
Yeah, thanks, Lucy. I'm going to suggest, if I may, that Chris picks up the question on stroke rehabilitation. I'll then have a go at answering the harm reduction one, although that is within Jill's area and she may also wish to comment. So Chris, could you pick up the stroke rehabilitation, please?
Yeah, of course. Lucy, this was very nearly a purple and closed. The reason that we chose to mark it as amber wasn't because the necessary progress had been made, but because of COVID. We'd chosen to move more services out into a wider range of community settings, and in doing that, in hindsight, created some fragility in terms of being able to staff across the different sites. That required the team then to regroup and pull some of that back to a slightly more centralised model, whilst staffing was as stretched as it was. And as a consequence, then they didn't just quite get this over the line. I've spoken to the team and to Gareth, and they're confident that they are all but there.
Thank you.
If I could I'll just kick off, if I may, by talking about the harm reduction point, Lucy, as well, that you raised. This is on page 12 of the report. I think it's QOP 8.1. We've identified some of the high risk specialties. They include general surgery, I think orthopedics, ophthalmology, there may be 1 or 2 more as well. And working with clinicians, we've used, I think it was originally an English risk stratification process that places patients into 1 of 4 categories from P1 to P4. That work has essentially been completed for those high risk strategies, and we're looking to see how we can develop our performance reporting. So as well as reporting on the numbers of people waiting, the total numbers, we could also look at that from a risk-based perspective, because we recognise how important that's going to be to us going forward as we continue to seek to deliver the most services that we can, but also the need to do that in a safe environment. So risk stratification is a key area from my perspective, and I will ask Jill if she wishes to add anything else. That was an amber, because if you look at what that action was about, we haven't yet completed that for all specialties. We've begun by focusing on our highest risk specialties. So that's my sense of that. Jill, I don't know if you would wish to add anything else.
Thank you, Mark. You've done a really good explanation there. What I would say is this work is ongoing. And it is clinically led. So this is a process that our clinicians are working together to prioritise patients against those criteria, those who are in immediate need of intervention versus those who can wait longer. The principles behind this is that people will change from one category to another regularly. So this will be an ongoing process, and it is taking place now across a number of specialties. The other one I would like to highlight, because it is a high-risk specialty, is urology.
Thank you for that, Jill and Mark. I think for me this actually highlights the importance of the actions being specific enough that it's measurable and clear to everyone what it means. It's a very high-level action, And clearly there's a lot of work that's been going on underneath that. And I appreciate Amber doesn't mean it's not happening. It does give us, there's a progress being made. But I mean, for example, you've got the high risk, as Jill's just mentioned there, you've got the high risk specialty for urology there's a lot of work been going on with that, and for ophthalmology as well. It's difficult to see that level of detail then actually in this report. It's very high level action.
Yeah, no, I absolutely agree on that, Lucy, and I think it does all come down to getting the right plan and the right actions specifically to begin with. I think for the Q1 plan, we had literally not much more than about 2 weeks to pull it together. And I think when we come on to look at the Q2 plan later in this meeting, and specifically the action plans that have been circulated before to board members, I think we will be able to see that the actions are vastly more specific and more measurable and more timed than they were in this plan, and that in turn will pave the way for the more kind of granular approach to performance management that you are seeking, I think, Lucy. Yes.
Sorry, if I may, just to support Mark as well, and he alluded to it at the beginning, is that we're trying to provide a read across to this, to the performance report going forward. So it will be, if you like, much more visible to the board moving forward.
Thank you.
I think it's important to recognise, though, two other things. The first is the executive assessment of the actions the executive team are carrying responsibility for. So, you know, this is about also transparency and trust to a degree. So we as a board, as our committees, are examining the validity of those assessments. And also there is the opportunity at any point for the committees, just as Finance Performance Committee has, to ask for more detail. And as you've heard already, we've done that in a number of areas for reasons that I think are justifiable. So there is definitely a balance to be struck. I don't think we're in the right place yet with that balance. Quarter two will, I think, help with that in terms of the plan and the performance report. But in the meantime, if there are concerns, as Lucy has highlighted here, then those concerns are capable of being examined, and certainly they are in some areas already. So I am going to suggest, no, I'm not going to suggest, I'm going to say now that we're going to take a comfort break because we've been going for 2 hours. I know we are behind the agenda, but there have been some really worthwhile discussions. So I'm going to pause us there for a comfort break and ask that you're ready to restart at 11:15, please. Diolch yn fawr. Iawn, mi hoffwn ni dechrau os gwelwch yn dda. Okay, I'm keen to start. So without further ado, Mark, we will go on to the quality and performance report, please.
Thank you, Chairman. As with the quarterly plan monitoring report, this report has also already received scrutiny at the Finance and Performance Committee. Unless indicated elsewhere in the report, this describes our performance to the end of May. Welsh Government performance management arrangements have been stood down in response to the pandemic. Nevertheless, our accountabilities as a health board remain exactly the same. Because of the pandemic, this is a modified report that we are currently submitting to the board. We're not asking managers across the health board to write lengthy narratives on performance at the present time. Neither are we including in this report any RAG ratings, any performance ratings, simply because to compare this against a target or to compare it to the same period last year would not be a meaningful comparison. The report contains information on our performance in a number of areas. It begins with some indicators on COVID-19. I think our sense is that we can develop this section of the report, Teresa, in talking about the TTP programme, talked about a dashboard that we are developing, improving the information that we've got around turnaround times. And I would hope that we can add this into our future reporting, also looking at testing numbers over time and how they are changing. The report also includes some information on essential services. Planned care work remains at very low levels compared to what we normally see, and because of that, it's absolutely essential that we carry out risk stratification exercises and focus on those patients who are in greatest need, and that may not necessarily be those patients that have been waiting the longest, which is perhaps been more of our approach in usual times. But there's a section on essential services and how we are complying with that guidance from Welsh Government. If you look at the planned care sections of the report, whilst we can see that waiting numbers remain fairly steady at the present time, this is mainly because we're seeing reduced numbers of referrals being received by the health board. The waiting time profile is worsening significantly with each passing month. This is a cause for concern for us, I think, and we're therefore seeking to resume services as much as we can. But crucially, we need to do that in a safe environment. And I'm sure that is something that we will touch on when we get to the Q2 plan in particular. In respect of unscheduled care, we're seeing that demand is starting to increase now from the very low levels of demand that we experienced in our emergency departments when lockdown was initially introduced. So demand is starting to increase, and therefore we're seeing some impact on our reported waiting times, although they remain very strong and a very good performance compared to previous periods. We are expecting that trend of increasing demand will continue across Q2, but we also know that a number of those attendances could have been avoided if other alternatives were available, whether that was about primary care, community pharmacy, self-care, or other approaches. I think those are the only things that I wanted to highlight by way of the report. I'm going to take it as read, and I'm going to pass back to you, Mark, and invite any questions on any aspect of this performance report. Thank you very much.
Okay, Lynn, I believe you've got a question.
Thank you for this report, Mark. On page 7, there's reference to screening services being suspended because of COVID, but then there is reference to them starting again in July. So the screening on that page refers to bowel, cervical and breast screening. I'd like to know, have we restarted them, and is there a plan to actually catch up to make the service, make sure that everyone's been covered who should have been covered? I did look in Q2 plan, and I don't know if it's my fault, but I didn't see any reference to the screening being re-established. Thank you.
Okay, thank you, Lynn. So screening programs will recommence in the second quarter. I think the reason why they don't feature in our Q2 plan is that those screening programmes are led by Public Health Wales or national bodies, so they are not our direct responsibility in terms of delivering those screening programmes. What is our responsibility is to respond to the results of those tests when they have been carried out, and the recommencement of those screening programmes will challenge our services to respond, perhaps most obviously some of our diagnostic services. So I think that picks up some of that, how that features in the Q2 plan. I'm not sure if any other exec colleagues would wish to comment any more on the details of the recommencement of those programmes. I think.
Shall I come in, Mark?
Please.
You can, Teresa, yeah.
Thank you. I joined a screening meeting earlier this week with Welsh Government, Lynn, where we were talking about the reinstatement of the programmes given the temporary pause by Public Health Wales. And so there is definitely planning underway, and the plan was that they would be reinstated, as you rightly say, from July onwards. And so they went through the programmes as part of that discussion. The elements I'm not so clear on is on the catch-up, because of course equally colleagues in Public Health Wales who undertake some of the screening and the knock-on elements, some of those have been deployed to other roles that are in a similar position as us, as having to work through each of the programmes individually. And of course, some of those programmes are very local, so cervical screening happens locally as such. So there are ongoing discussions, but yes, the planning is underway. And I know that links are being made with the key colleagues in secondary care and primary care, given that there's overlap of the programmes. And not all programmes stopped, and I was glad of that. Thankfully, they didn't stop all screening programmes temporarily. It is just those that you've mentioned. So the breast test, the cervical screening, the bowel screening, the abdominal aortic aneurysm screening, and the diabetic eye. And of course, Public Health Wales will need to consider in terms of any impact on patients and any harm from their perspective, and that will be led by Public Health Wales.
Although you say it's led by Public Health Wales, and I fully understand why that's said, it is a vital, crucial link for our prevention, for our population health. So yes, it may well be Public Health Wales, but it's still a core element of our function.
You're right, Public Health Wales actually undertake that on behalf of us and our population, really, in terms of the relationship. You're spot on. And I was worried when screening was paused. Thankfully, immunisations continued, although we know some people haven't come forward for those as we would wish. So we've got to do some catch up there as well. But you're right, this is backbone work for us as a health board in terms of our health and well-being. So it was a good conversation earlier in the week, as I say, with Welsh Government. It feels that the work on the harm element is being undertaken and led by PHW, and they will link in with us. And we've been having regular meetings between officers of the Health Board and PHW pre-COVID. They've been keeping us informed during these phases of COVID, but clearly going forward, we need to understand all the plans. And I mean that from the Health Board elements that we look after and the PHW-led elements as well. And then hopefully we can give you assurance on the catch-up. And of course, the annual report gets submitted normally to the SPPH committee. Yeah. I'm assuming that that will be delayed this year, but I'm hoping it will be with us maybe Christmas, January time.
Okay, thank you very much, Teresa. Thank you.
Yeah, Teresa. Cheryl, you have a question?
Yes, I do, Chair. Thank you very much. Thanks for this, Mark. On page 12, you talk about the CAMS figures. And while I welcome the extended opening hours to 10 o'clock at night to support young people in crisis, I am concerned that you say outcome data inputting was problematic and it's currently being addressed and updated, but there's no timeframes for this at all. And this data is crucial. We really need to know where we are. As you know, I have very long standing concerns about this service and you know, where it's going. So I'd really appreciate that. Thank you.
Okay, thank you very much for your question, Cheryl. These are important services. I would need to take that away and have a look at that, which I'm really happy to do. I don't know if Chris would wish to add anything else, would wish to add anything to that. If not, I'm happy to take that away and get back to you.
I would agree with that, Mark. I'd need to go away and look for confirmation.
Okay, Cheryl. So we'll take that away and we'll get back to you with clarification on that point. Thank you.
Thank you very much indeed, gentlemen.
Okay, so I've got a couple of observations myself. The first is, Mark, that of course, as someone said earlier on, we need to make sure there is a correlation between areas of concern in terms of performance and the Q2 plan and the action plan that sits with it. We can make our own judgment on that, but can you give us some assurance that the construct of the plan for the next quarter, or this quarter as it now is in keeping with the concerns that have been identified through the quality and performance report?
The performance report is focused on the full range of indicators specified by Welsh Government that we are accountable for. It's aligned at the moment around the quadruple aim, which is a Welsh Government approach to defining the ultimate outcomes really for the patient population that we are expected to achieve. And yeah, I believe it does align to the plan, but I think that's a level of detail that we need to kind of test out on a case by case basis. The format of it, as it has done for a number of years for the Health Board, focuses on the key areas that we are expected to deliver.
Right. So with that in mind, we talk about a number of areas that are in the quality and performance report. Then, so Jill, let's talk about unscheduled care first, please. So performance has been strong during the pandemic, but of course that's been helped by the attendance rate. The attendance rate is now going up. I would hope that we're looking to embed any change of practices that were put in place during the pandemic response that will help us deal with an escalation in numbers into our emergency departments. Could you give us some sense of that, please? Jill, are you there?
Sorry, Chair, I was on mute. Apologies.
Okay. No worries.
So in terms of, yes, we're very, very aware. We're very, very aware of the increase and monitoring the increase of unscheduled care, and clearly we're cognizant as well that with the lockdown being released that we're likely to see more visitors across North Wales, and we know that that always influences our demands on unscheduled care. The work that we're currently doing aligns with the Health Minister's statement, I think came through yesterday, in terms of working with our partners and our CCAT services, particularly to see how we can manage the demand through our services by managing them via an appointment system where appropriate. We're also using some of the learning from our COVID. So we are using Consultant Connect. I'm sure Chris would confirm that that is being used now more and more regularly across primary care to access support from secondary care colleagues to prevent admissions into emergency services. So I think that those digital options are actually now being used quite routinely across the Health Board, and we've got plans to roll those out. We've also put in place an unscheduled care board, which we will be working with our partners and stakeholders to see how we prepare for winter. Alongside that, we're cognizant of the potentials for another increase in surging COVID, as well as the impact of potential flu or any other infections that we generally see as we move into winter, including norovirus.
Thanks, Jill. Do you just want to mention the recruitment of new directors to the hospitals, please?
Yes, happy to. So I think it was mentioned earlier that we now have an interim chief operating officer who is responsible for secondary care, but also for supporting the performance across unscheduled care and planned care, as we've alluded to. And we have recently been successful in appointing 3 acute site directors to each of our acute sites. So Bangor, Ysbyty, Gogledd and Ysbyty Wrexham. One of those is now in post, and we're expecting the second to take up post in September. The third is given 3 months notice, so we don't expect to see them for a few months yet.
Okay, thanks, Jill. Can we turn to diagnostics, Adrian? So waiting lists are increasing. Two particular area concerns are endoscopy and radiotherapy, which are seeing the largest increases. Could you comment on both those areas, Adrian, please?
Of course, Mark. Yes, I think, as you say, two areas that have increased are endoscopy and I think radiology, as opposed to radiotherapy. So endoscopy, I think we know that access has been challenging, and our capacity has decreased somewhat due to social distancing, cleaning down rooms, and everything in between patients. So it's probably down to about 50 to 66% of what we can do or what we were doing. And we also had staff redeployed to cover COVID areas. We've introduced fecal immunochemistry testing, immunochemical testing, looking at screening patients in secondary and primary care some of whom are waiting and some of whom may be referred by GPs in order to screen them, obviously in the best way, so that they don't need a scope, they don't get one. We're looking at insourcing activity as well, and where we might be able to do that. And we're working closely with the National Endoscopy Board. I guess we touched on bowel screening before, and we know that is starting up, and there is a close discussion within the access meeting about how we do that, because that doesn't just have an impact on endoscopy, it has an impact on surgery as well, potentially, and looking at all of those aspects. So within radiology, I think the paper notes too that obviously, there's been a reduction in capacity there as well due to the same issues. More of an impact in CT than in MR and ultrasound. So we've got some activity continuing at Spire. We're looking at additional CT scanning capacity in YG, potentially extending the lease of a unit that we already have elsewhere in the unit. I think when we looked at comparative numbers with other health boards, we were fairly comparable in our activity as a proportion of Wales in the data that I saw last week. So the teams are working hard. There's a lot around the actual just the capacity that we can use. Also looking at plans to develop there around insourcing and using more of that capacity at the weekend, potentially, or the scanner.
Okay, I lost you a bit at the end, but so Kate Clark from Secondary Care and I went to the endoscopy unit at Wrexham last week. Really helpful visit to see what was going on and what they were doing to maximise their capacity. During the course of which there was reference to insourcing, Adrian,
yeah,
the potential use of a temporary hospital or other site to facilitate insourcing. The central concern was around the fact we don't have enough staff to support insourcing, so we'd have to insource staff too. So
yes,
you refer to that. Where are we in that examination, please?
So that's out to procurement at the moment, Mark, so that we can take that forward as soon as we can. So we're doing what we've done in previous years. We put it out to procurement, and last time we retained a number of companies to provide some of that insourcing activity across North Wales on different sites.
Okay, thank you. Michael, I think you may have a question around diagnostics.
Thank you, Chair. Yes, I've been trying to do a bit more diagnostic work because some of my cardiac work has been discontinued. And one of the things that I've come across is the need for better IT solutions. Diagnostics is pretty good on IT, but and we outsource a lot of work in terms of reporting. But we've had some difficulty in getting people who need to shield being able to report at home, and we need to do something about improving the IT solutions there. The other thing which Adrian has alluded to is the provision of kit, that because of social distancing and COVID.
Michael, you're hard to hear. Could you speak up, please? Sorry to cut across you.
Okay. Take my mic. Can you hear me now?
That's brilliant. Thank you.
Okay. Throw away my microphone. One of the other problems is provision of kit, which Adrian has alluded to, that the existing kit can only be used less frequently because of social distancing. So I'm reassured that we are going to get a bit more attention to provision of kit. My initial point was IT solutions to make sure that people can work remotely and safely and report. And some of those things I think are relatively simple IT solutions which we need to put in place.
Okay, thanks, Michael. Adrian, did you want to respond to that in any way, shape, or form?
I think one of the key ones is around the outsourcing of reporting, and we did at the beginning, Michael, of COVID, you might know or may not know, invest in a number of home reporting stations, which I know have been really successful. So we have tried to do that as much as possible. That was from the point of view of people who were shielding, and also from the point of view of people who were isolating at home, so that if they were well, obviously that they could continue to support the service. I think there definitely is some national work going on around the amount of the number of imaging, or the amount of imaging that we actually have, and where we are in comparison with other OECD nations as well. And there's a review that's due to come out by Professor Richards, I can't remember his first name now, where they've done a very big review in England, and obviously we'll be looking at that very closely within Wales as we go forwards.
Okay, thanks both. Jill, can we now turn to plan care, if we may? So, of course, the other area of concern is some of our elective services being on stop during the pandemic period, albeit, of course, some important ones carried on. And notwithstanding the complexities about restarting some of those services, you're giving close consideration to it, I know, as is the executive team. Can you just tell us where we are now, please, in terms of the restart of some of those services that we have been lacking for a little while?
Yeah, happy to, Chair. What I would say at the outset is we have managed to keep some services going, particularly for that higher risk population. And in doing so, we have utilised the Spire, but we've also used some of our own capacity to mitigate as much of the risk as we can. What we have developed over the COVID is a number of pathways, and included within those are planned care pathways. These are clinically led and clinically driven. And what we've seen as a consequence of that is our clinicians coming together to prioritise those patients' most urgent need of treatment, but equally develop a single pathway for North Wales, which means that wherever you live across within our region, you will, if you require the next available slot or from clinical need, you will get it. As a consequence of that, a number of our clinicians are now travelling to undertake surgery in other parts of the health board, but we are also offering patients from one part of our health board to go to an alternative location so that they can access the treatment in the safest, most timely manner. Endoscopy actually as a diagnostic has been an example of this, and we have seen patients travelling from the centre part of North Wales into the western part of North Wales in order to access that important diagnostic as quickly as possible. This process is now being applied across urology, general surgery, orthopaedics, ophthalmology. So our clinicians are working as a community to ensure that, as I say, that the patient with the highest priority is treated at the earliest available time. That does mean that we aren't taking necessarily in chronological order as we would have previously seen. We are taking them in terms of clinical risk. It does mean as well that our patients are having to travel up and down the health board, but equally so are our clinicians if that's felt most appropriate. And it is is in line with a consent process, so that our clinicians are fully informing patients if that has to happen. So, for example, at the moment, the Spire is being used for some of our highest risk orthopaedic patients, and the first cohort of those patients are coming from the centre of our region.
Thanks, Jill. Can you just comment specifically on urology? Some correspondence arrived this week from a number of patients about delays in urology. We know it's a pressured service. I've just committed to undertaking interviews for new urology consultants. So, and I know there is a service review going on too. So, can you just tell us where we are and to what extent urology is being prioritised given the concerns now arising?
So urology is being very highly prioritised. It's one of the, if not the highest priority service, alongside endoscopy. For example, those clinicians, I have to say, have been very proactive in agreeing that pathway and risk stratifying their patients, and they are already beginning to implement that pathway. So in terms of the priority, it's very much there. We're also looking at our lists in a very different way. So on a weekly basis now, we are managing that list on almost a patient by patient basis to ensure that the pathway that's been agreed being followed. And as a consequence of that, we have just re-engineered our dashboard to ensure that we're looking at the list as a holistic North Wales approach.
Thanks, Jill. Sue Green, can we come on to sickness? The table shows May sickness, but I know there was an improvement in June. So in terms of care and support for our staff, can you just give us an insight in terms of where we are with sickness and what's going on, please?
Yes, certainly. I think so. So as you said, we've seen an improvement in June, and we've definitely seen an improvement in COVID-related absence in June. We're being very mindful of the impact, both physically and psychologically. So, and colleagues from the exec team and beyond have been very heavily involved and supporting the wellbeing hubs. So the staff wellbeing hubs that were established during the COVID pandemic, but we are maintaining, and we're just working through developing a proposal for continuation and development of that model going forward. There is no doubt that they have been received very well by staff. They have been accessed by significant numbers. What we want to do is to try and extend the way in which staff can access those services, so they can do so not necessarily just physically. So as well as that, we are reintroducing and reinvigorating in partnership with our trade union colleagues the work that we were doing around the specific kind of hotspots categories, which were stress and anxiety related, which are clearly supported by the staff wellbeing units, but also musculoskeletal injury was another element, plus long-term absence, and particularly with long-term conditions. That's something that we had already identified, particularly given the demographics of our population and our workforce. But also during the pandemic, that has come into stark relief when we've been looking at our vulnerable groups and our protected characteristics, and of course those members of staff who have received shielding letters. So we've got around 500 staff who've received shielding letters because of an underlying condition or a comorbidity. So it's really using that intelligence now to put a much more focused and targeted support program in place, particularly as shielding is paused. I suppose the only other thing I would say is that we've had lots and lots of people working remotely and working from home. We have been very clear that we want that to continue until we're absolutely sure around our ability to provide safe premises and safe working. But we also want to recognise that there needs to be kind of new ways of working moving forward, but the impact that can have both on people's physical health and well-being and psychological health and well-being So we pulled together a team, which is a joint team and partnership to really look at how can we sustain a level of agile working and remote working while still making sure that we're protecting people's physical and mental health and well-being. Don't know whether that answers the question specifically. If I've rambled on, then I'll be quiet and listen to a more specific question.
You answered the question. You didn't ramble on. Thanks, Sue. So we are asked to note two things in terms of that report. I will assume that we have noted it based on the questions and the discussions that we've just had. So we'll now move on to finance. Eric, I know you're representing Sue, who can't be with us. We've got finance 1 and finance 2 in terms of months listed. I suggest we note month 1 and we turn our attention to note 2. So you can assume those documents have been read. Is there anything you particularly want to highlight, Eric?
Thank you, Chair. I just wanted to pick out particularly about the impact of COVID-19, and obviously this is the first time that the finance report has been reported to the board in this financial year. So just to remind board members that we are planning a deficit of £40 million this year, which is predicated on delivering savings of £45 million. However, the plan obviously did not take into account the impact of COVID-19, which is obviously having a significant impact as we work through the beginning part of the year and throughout the rest of the year. Consequence, we are reporting a balanced position in month 1 and 2. And this is predicated on the assumption that Welsh Government will fund the full impact of COVID-19. I have to state that is a risk because the confirmation of funding has not been agreed and we're not quite sure when we are going to get full notification of what our allocation will be. Just moving on to page 3 of the report, it sort of picks out what we have spent on COVID-19, and there's just a few principles I'd like to talk about. We've got the field hospital costs, which are predominantly shown in month 1, which is the setup costs of those hospitals, and then the running costs thereafter. We are assuming that we are going to start using the field hospitals at some point this year, although the exact date is yet to be determined. On elective care, we are obviously saving money because, as we've previously discussed, we are not undertaking levels of activity which we had previously expected. So we are making quite significant underspends, particularly around the acute hospitals at this moment in time, of millions of pounds a month. However, we're obviously not saving hardly at this moment in time and delivering our savings schemes, which is an area which Welsh Government have asked us to really focus upon over the next few months. One other point I really wanted to make was about the contractual arrangements which are now in place, particularly with other organisations, and that includes English NHS providers. There is agreement to basically pay them block values, even if they are not undertaking any particular activity on our behalf at this moment in time. And obviously that's to ensure that there's cash flow around the system and to ensure that there is some stability. We are continuing to have discussions with these organisations about them undertaking more activity, particularly over the coming months, as things are settling down and we are getting to a new state of normal. We've also introduced a finance governance cell to review the expenditure that we have had against COVID-19 particularly. We know things have been done very quickly and we want to make sure that we've followed the rules as much as possible, and anything that falls out of that will report it to the Finance and Performance Committee. They're the key things I wanted to highlight, Chair. I'm happy to take any questions.
So, John, you have a question, I believe.
Yes, thank you, Chair. Just a question around saving schemes. Obviously, the report highlights the under-delivery due to COVID-19, but what's the gap of identified saving schemes to be able to meet the 45 million gap, assuming we were delivering according to plan?
Thanks, John. Things have progressed into month 2 as you would expect, and we're now around about £13 million worth of identified saving schemes, which is still quite low, and we know we've got a lot more work to do. We're trying to benchmark where we are across Wales, which is proving quite difficult because everyone's made different assumptions. We are pushing with Welsh Government and the Finance Delivery Unit to have a bit of consistency. Clearly more information will come out and we'll report that through the Finance Committee and the board as when we have that information.
sorry, to follow up that, are we actually looking at filling that gap? Is there work going on to fill that gap in terms of the pipeline of savings?
We are definitely looking, John, to fill some of that gap. Whether we'll get to 45 million, I think that would be a very strong ask of us this year. And I don't think any health board is assuming that it will deliver their full savings programme due to the impact of COVID-19 predominantly over the year.
And forgive me, final point that, does that mean you will be adjusting the forecast of where we will, our final year-end position at some point soon then?
Yes, yeah, undoubtedly. The key risk that we are facing is we need the clarity on what Welsh Government will fund in respect of 19. Once we have that, that will give us a bit more certainty on what the numbers will look like going forwards.
Lucy, you have a question?
Yes, thank you, Chair. I just wanted to ask really about, notwithstanding the savings programme and our previous plans, obviously COVID has had a significant impact in the way that we're working, including the requirement to increase the level of virtual working that's done, virtual clinics, and the additional digital platforms that have been required. Have we factored in the additional support and resource that will be required for IT as a result of COVID?
Yes, we have. We now send quite a detailed report back to Welsh Government on a monthly basis. It has been reduced due to the impact of COVID-19 over the first few months, but one of the things that they have introduced is quite a detailed forecast relating to COVID-19. And that includes all the staffing requirements in terms of whole-time equivalents, what we're going to pay the student nurses that was referenced earlier. And that does include additional staffing for IT, who have been fantastic helping us through the first few months and helping everyone to deliver agile working really in a very short space of time.
So that's in relation to staffing. What about in relation to the additional costs? Because I believe actually the IT department's budget has been cut as part of the savings programme for the health board. I'm concerned about the additional software that's required, the additional support that's required as part of that.
Well, all departments have a requirement to deliver saving schemes through the year, but in terms of additional costs which are required as a result and the direct impact of COVID-19, they should all be funded. There shouldn't be any issues.
Okay, Sue Green, did you want to come in? Sue?
Yes, Chair. It was in support of Eric. He's doing a sterling job. The exec team have, and to answer some of Lucy's points, the exec team have recognised, and as part of the kind of the lessons learned and recovery work that Chris alluded to earlier, recognised that there are a number of opportunities as a result of the pandemic that we need to make sure that we don't lose, and one of those is absolutely around really reviewing the use and the deployment of information technology to support better accessibility for patients, as well as new ways of working for staff. So that's something that we have reviewed. We've identified that from an IT point of view, informatics point of view, we need to review how we can resource, but also accelerate some of the plans that were already in place. So, for example, Microsoft 365. Some of the software purchase, the required, as well as the hardware purchase. So that is something that is being worked through by the executive team to make sure we don't lose the benefits of improved access using digital technology.
Thanks, Sue. So, Eric, a couple of observations from me, and I guess it's worth noting again that this report has been examined by Finance Performance Committee, just like the performance report. But in terms of this report, so I think it's worth noting that Simon, as our Chief Executive, has written 2 accountable officer letters to Welsh Government. So we've been very transparent around the costs that have been incurred. across different parts of our expenditure profile, including the temporary hospitals. Could you just confirm that's the case?
Yes, I can confirm that's the case, Chair. And we are part of a small group of health boards in Wales which are being audited as well on the cost of the field hospitals, and we've currently got KPMG currently reviewing the costs. Okay, second thing from me is consideration is being given to the use of the field hospitals. Adrian most recently has referred to two of them being used for phlebotomy services. Presumably, Eric, someone from finance is keeping an eye on what we're using them for and the expenditure associated with that, because, for example, we wouldn't want to run the hospitals to their full degree and incur maximum cost if that's not required in terms of those services we're agreeing to put there. Yeah, absolutely, Chair. We're linked in across finance a number of work streams that are ongoing, such as what you've just described, with the digital diagnostic work which is planned, with the Spire Hospital which is currently being used in Wrexham, and we are trying to pull all this together and make sure it goes in our forecast, and as you have said, in a completely open and transparent way with Welsh Government. Okay, third thing for me is we had quite a conversation around the savings programme. We're expecting a report back before the next Finance Performance Committee about how we restart the savings programme and to what extent we are confident that the current savings streams that are listed in the last report to Finance and Performance Committee are deliverable. So I'm guessing you and Sue Hill are putting that together for Finance and Performance Committee. Yes, and we have got a quite high degree of confidence that the schemes provided so far are going to be delivered, because they've all been put forward by the individual directorates and divisions, and we constantly go back and ask them to revalidate their numbers. So for me, that gives us quite a high level of assurance about those. The key issue, as I think, as we mentioned earlier, is making sure we've got more schemes coming through the pipeline to increase our savings delivery this year. Okay, and finally for me, you've commented on this and it's in the paper. So in terms of points I wanted to highlight, so the finance governance cell has been established to ensure that our expenditure is fully justified, represents value for money in a COVID and non-COVID sense. Yes? Yes, absolutely. Okay, and then finally, I've got two questions then. The first is perhaps for Sue Green to start on, and perhaps you, if you need to, Eric, to make any further comments. So expenditure in terms of total pay, Sue, for May, I know we're now beyond May, but this is the report that refers to May, was up markedly. I can no doubt understand why, but it would be helpful to get a sense from you as to why it's gone up so markedly and confirm the reasons for that, particularly given substantive, I think, expenditure went up too. So Sue, do you want to comment on that, please?
Certainly.
Thank you.
So not unexpectedly, we recruited and quite successfully recruited additional members of substantive staff, but also additional members to our bank workforce. And as Jill and Adrian both alluded to earlier on, we had some really helpful support from students, both nursing and therapies and medical students. The additional expenditure we have tracked and continue to track in terms of being sure what is directly COVID related and what isn't. We're also being very mindful as part of the governance review that yourself and Eric just referred to make absolutely sure that we can demonstrate that it is definitely COVID related. We're also using that to identify whether, given a little bit more time, we could find alternative solutions to that expenditure on a more sustainable way.
Thanks, Sue. And then finally, so going to Lucy's question, and notwithstanding Eric's helpful answer, on page 19, there's the capital programme and transformation schemes listed. John, can I ask you, as chair of the Information Governance Committee, to examine further whether it's felt that we have the resources in terms of both people and finances to not only deliver those schemes, but to deliver what is required around Attend Anywhere, Consultant Connects, and those other things that we put in place during the pandemic. And if there is a gap, to highlight that to board and to the executive team, please.
Yeah, I'm happy to do that. I think it's something we've got to examine.
Okay, all right. So we'll have that as an action, if you don't mind, John, for you in that committee.
No problem.
Thank you. So our colleagues happy to move off of the finance report?
Yes.
Yes.
Yep. Okay, so that report is also noted. Thanks, Eric, for stepping in for Sue. So we now move on to committee and advisory group chairs' assurance reports. And whilst these are for discussion, I'd ask us to accept that they've been read, and I'd ask the chairs concerned just to highlight any particular points they wish to highlight, and in doing so, keep it relatively brief. So without further ado, Medwyn, audit is the first.
Diolch yn fawr iawn, Cadeirydd. Dyma adroddiad Pwyllgor Archwilio 9 o Mehefin. This is my report on the meeting, the audit committee meeting on the 29th of June. And as we just heard from Eric, COVID-19 continues to represent a significant risk both to the health board's financial position and the ability to progress business as usual, which was the main issue of the meeting, actually. COVID-19 had impacted progress made against recommendations in the audit track, and further discussions between members in the executive team and auditors are to take place to agree a way forward in terms of capturing progress on all tracker recommendations, some of which obviously have stalled during this current situation we find ourselves in. The risk management strategy policy was approved in principle, and further assurance in terms of implementation dates were of a concern, and we will no doubt hear and have an update during the risk management strategy paper later on that front. As a result of COVID-19 pandemic, internal audits have not been able to complete the audit programme in full. However, they had undertaken sufficient audit work during the year to be able to give us an overall opinion of reasonable insurance. Internal audit had anticipated, after adjustment to the original audit plan agreed with the audit committee, to produce 33 outputs for the year. However, due to the impact of COVID-19, the final position was 18 final reports, 13 draft reports, and 2 work in progress reports. So it was a reasonable an assurance from the internal auditor, and the committee also revised the internal audit plan moving forward, which has been updated for COVID-19 impact, and that was approved. The recommendations relating to the clinical audit, well, whilst progress on the clinical audit itself has been made, and significant progress has been made in the last 2 years, due to COVID-19, there is currently no clinical audit activity being undertaken, and at present the national programme has also been suspended. So those were the main headlines, Chair.
Medwyn, any questions for Medwyn? No? Okay, Lucy, nothing to escalate to board, but anything you want to highlight in terms of QSC, which is the next report?
Thanks, Chair. Just to confirm really that during COVID, as a result of the pandemic response, of course, most committees were stood down other than the audit committee and QSE committee, during which time we ran a more focused and risk focused agenda. A number of the risks that we've discussed at the committee, which is in my report, has also been discussed actually at board today in relation to the reduction in referrals and the reduced access to services. Of course, it's also been noted the backlog of waiting lists is increasing as a result of the non-essential services as well. We've also discussed today about the avoidable infections and cluster outbreaks amongst both staff and patients in relation to COVID. We are reconvening the QSE committee on the 29th, and we'll be scrutinising those areas as part of our as ongoing agenda items. Unless there's any questions, that's all.
Any questions? No? Okay, Finance Performance Committee is next. I chair that. We've already discussed finance and performance, so I don't want to dwell on the assurance report. There has been a further meeting since. So the assurance report from that meeting will come to the next board. RATs has also been circulated. You'll see the matters that have been discussed for RATs Remuneration Committee, Robert, and there's no matters requiring escalation. So unless anyone's got any questions, I'll leave Remuneration Committee. And so we're on to SPPH. Lynn, anything from your good self? Lynn, you're on mute.
I do apologise, Chair. A lot of the comments that we raised concerns on have been covered today, including research and innovation. We have asked for a number of further reports to be developed over the coming months to do with our emergency preparedness. And as a committee, we were aware and we did have some issues initially about our involvement in the establishment and the creation of Q1 and Q2 plans, but we've discussed that with yourselves and other chairs, and we appreciate that the board is taking the lead on Q1 and Q2. However, we do expect to be much more involved in further planning and the monitoring of these plans. Thank you.
Thanks, Lynn. Any questions for Lynn? No? Okay. Charitable Funds Committee. Jackie, anything from you?
Thank you, Chair. I just got a couple of comments I'd like to make, particularly around the work undertaken by the charitable funds team currently and throughout the COVID pandemic. They've worked exceptionally hard and made sure that funds have been available for staff to use. We have established the COVID-19 staff wellbeing fund, which we continue to use to support staff during this time. And just to highlight that any requests for funding have been approved offline using the required quorum, so that work has continued and to highlight the key risk potentially around the staff lottery when we get round to establishing it. Thank you.
Okay, any questions for Jackie? The support of the charity, as you know, Jackie, is being well recognised. Certainly at Llandudno Hospital, there was some really positive comment made around the support that they're getting in terms of practical assistance to do what's required. So that was very welcome.
Thank you.
So we move on to Information Governance Committee. John, anything from your good self?
I think we can take the report as read in general. I'd want to praise the informatics teams and the information governance teams in terms of their rapid response to deploying technology and dealing with some of the information governance issues that they've had through the crisis period. If there's anything to highlight, is that it's that since the last meeting, one of the risks we've got, which is about national systems, we've had another national systems failure in 2 data centres down in South Wales, and I've still got some grave concerns about the reliability of national infrastructure and our ability to have some governance and influence over the way things are structured. It's something we'll examine next time, but it's still concerning that we're having regular failures with national infrastructure and systems.
Thanks, John. So if you examine it next time and there's any concerns that we need to escalate as a board, again, could you let us know and we'll pick that up, Simon and I?
Yeah, will do.
Thank you. Any questions for John? So we're now on the Health Partnerships Forum. Anything from you, Michael, as Vice Chair?
One observation and two comments. The observation is that the HPF is a committee of busy clinicians, and we had the best attended meeting because we didn't have to travel. So it was an electronic meeting, which was very useful, very workmanlike. But reducing attendance in terms of face-to-face seemed to improve our attendance. The two comments I wanted to make was on the use of sharing and keeping up to date with science, which the committee felt was important, and using learning from COVID in terms of use of IT workspaces which we could use to share information, particularly in relation to developing clinical services and the clinical service pathways, rather than having traditional meetings where you gather the same people in the room who come to the same conclusion. So what we've learned is that by increasing the number of people and increasing the availability, we develop and share good ideas. Second point, I think, is quite important in that I've been keeping note of the attendances at our staff wellbeing centres, and roughly 10% of our total complement of staff are attending wellbeing centres over this period, which gives us an indication of the degree of stress that staff are under, and we've been looking at the range of things that they've brought to these wellbeing centres. The risk is that we may think that the crisis is over and these wellbeing centres are wound down. What we're now seeing is ongoing issues of anxiety, particularly has been referred to with staff returning to work, but also longer term effects of COVID, both physical and mental. And that, as we understand a bit more about this, I think there's going to be a need to make sure that we have an agenda to support staff wellbeing on an ongoing basis.
Okay, Adrian, I believe you want to comment.
Just really quickly, please, Mark. It's just in the advisory group chairs report. It's got chairs and members written updates. It didn't include the update from the secretary and tertiary care representative Michael in that list. So I just wanted to note that, please, for the board, and apologise to Michael for missing his report in the list. Although it does note on the back that there was obviously he did mention issues. So thank you. Sorry, Michael.
So, Sue, would you like to comment around the wellbeing hubs in terms of the future or moving forward?
Yep, I can do. I think I mentioned this a little bit. Michael and I are a bit of a double act today. I think I mentioned this a little bit earlier. They have been sustained. We are working really closely with colleagues who are on the group that set the hubs up, with psychological therapies and with occupational health and well-being, to put together a case for investment moving forward, both in terms of commitment from the health board and potentially investment financially. I believe it will be an investor save, and is something that we've already demonstrated the impact of, and can do a good job of demonstrating the impact moving forward. So very committed to pulling that case together to sustain the model of service going forward.
Thanks, Sue. So I'm going to move us on then to stakeholder reference group report. Frank on. Frank on, can't hear you. I can now.
Can you hear me now?
Yes.
Okay. Yeah, we had a presentation from WAST. So we were reassured that they are providing an equitable service between rural and urban areas. That had been a concern of the group for some time. We went through the Q2 plan. Just 2 points we'd like to bring to the board's attention, which have been covered in the plan. One is the importance of communication with patients and families in this difficult time. And secondly, the importance of partnership working, which we've heard a lot of this morning in this meeting. And the final thing is the third sector, and I'm a bit like a broken record. Just want to re-emphasise the importance of this sector and how it links to health board's activities, but also how complicated some of the coordination activities are, and for the health board to consider resourcing those links appropriately, especially given that a lot of the third sector resources are being stretched, particularly as a result of COVID. Thank you, Mark.
Thanks, Frank on. So unless there are questions, I'm going to move us on once again. So we now move out of the assurance reports and we move on to the vascular services update, David, in terms of the independent review. I can't hear you, David.
Apologies. I'd like to update the board on the progress that came after the review of the vascular services. There have been 2 meetings of the Vascular Task and Finish group which have been well attended, particularly with the Community Health Council and patient representative. It was agreed at the first meeting to co-produce the application for an external invited review from the Royal College of Surgeons. Meetings were held in between the first 2 meetings, and the draft of that submission was presented on Friday last week. It was agreed that I'd take chair's action when final comments have been received to the chair of the Quality and Safety Experience Committee with the proposed scope of the external invited review, and then if approved we can send it to the Royal College of Surgeons with the expectation that work could start early autumn. So it's been an important piece of co-production, and I think it allows us to agree the scope of the review and provide assurance in due course that builds on the previous invited review in 2015. I've also included a summary of the first update to the Quality, Safety and Experience Committee. We've had 2 meetings, we're getting underway. It's important that we listen and form as a group, and that's been well received, and we've had feedback from the Community Health Council that their representatives are feeling listened to and fully engaged in the process. We've been looking at the timescales for some of the actions and reprioritised because of the complexity of the work. But what we have been able to do is start the communication engagement plan. We have been able to look at some of the risk areas such as antibiotic prescribing and the amputation performance as mentioned earlier. The meeting is held every month, and we'll continue to report against the actions to the Quality and Safety Experience Committee. I've also drafted a response to Welsh Government. They wanted to know about the progress and wanted an update every 2 months, which we agreed before the board meeting. And I think I'd like to say overall we've got engagement, more people are getting involved, and using the process we've adopted, it will be able to provide assurance through the Quality and Safety Experience Committee that we're making a difference to the vascular service across North Wales. I'll end there. Thank you.
Helen, I believe you've got a question.
Sorry, I don't actually.
All right, your hand is up, I'm told.
Oh right, it was actually just to it was to just echo that the point that Frank had made in about the stakeholder reference group and the challenges for the sector in capacity terms. So if we need them to be engaged, I agree that some form of resourcing around that or finding smart ways of engaging them is really important. So apologies, and I should have taken my hand down.
Okay, thanks. So David, a couple of questions for me. So ensuring the right people are represented in that task and finish group is key, both in terms of assisting to ensure improvement, but also engagement and competence. You've already referred to, I think, working with Anthony Dixon and colleagues, but also you've referenced the CHC. So are we content that the group is given enough to a patient's voice and experience in terms of the work that's going on?
The group feels it has. It's only met twice. We've also suggested we have nurses from the area teams to be involved, and also somebody from the vascular service with an educational lead. So we'll continue to review the membership, and the patient representative is very dynamic and very proactive, and it's a way into further work with the CHC. We've also agreed to have a visit to the service with the CHC in a couple of weeks. And I think it's an area that will keep growing and developing and building a network to help the group achieve what it can achieve. So we month by month in between, we'll be also looking for opportunities to build the network across the organisation to ensure those who want to participate are welcome and able to do so.
Okay, and in terms of the report, it refers to the need to secure project management support for the non-arterial diabetic foot pathway work. Has that been secured, David, or is it to be secured imminently, given what we've already discussed today?
Yeah, it hasn't been secured, but we're looking at other resources we can free up during the phase we're in terms of the pandemic to prioritise that work. And I think it's important that we do that and are explicit about that. Otherwise, our timetables may slip. But I've been impressed by the number of people willing to help with this, and I think we've got a lot of people that want to use their time. So it's the coordination of resources that we already have is to me the key part. But there will be a need for project management support, and I'll make sure we find that too, and I'll let the work continue.
Okay, and then finally, you may have touched upon this. If you did, I apologise. But timescale in terms of the independent review, then I see we're drawing up terms of reference. We've approached the Royal College, but
yeah,
what are we looking at in terms of time?
Well, I'd like to think the submission will be end of this month or early August, and we would expect probably September onwards would be the beginning of the desktop review, and then a site visit after that. So it would be in keeping with our initial view at the time of the board in May actually, that we'd have the review starting within 6 months. It would give the task and finish group time to make a difference as well, but I don't think we're losing time at all. Actually, the key bit is to get engagement with the CHC and others to make sure the scope is right, and it's going to be that the review will undertake the work that we really wanted to undertake. So I'll work with Lucy and the QSE committee to ensure that we expedite that application to the Royal College in the next week or two.
Thank you. So I think John has got a question. John.
Oh, thanks, Chairman. It was just a question, David. You mentioned earlier about overprescribing of antimicrobials. I just wonder whether the review was going to pick that up as well.
Thank you, John. I think it will. Part of the reason to bring in some of these new areas of inquiry, so the antibiotic prescribing is one of them, is to ensure that we have the most comprehensive review that we can. So by keeping that work within the task and finish group, it will ensure that the invited review will oversee that and be able to scrutinise that work, so that it becomes, because what I would expect them to do also is to ensure that they scrutinise the work of the task and finish group, including these areas. I think it's an important area to focus on because of the lessons that can be learned, and I think we have the expertise within the pharmacy team to provide a very detailed analysis which will be useful for other services.
Thank you.
Thanks both. Lynn?
Thank you. Thank you. David, you've clearly done an awful lot of work, especially with your meetings of the task and finish group and your conversations with the CHC. I'm a little bit disappointed with this report for a number of reasons. One is that because it's not as updated as I think it should have been, so it's disjointed, and I'm not clear about what actually has happened on these action plans and what hasn't. So for example, the draft vascular service improvement plan gives a number of actions, says draft, and it says when they should be achieved, but doesn't actually say whether they were achieved. And then when we go on to the following appendix 3 to do with engagement and communications, this is well and truly out of date. This is dated for your task and finish group meeting on the 16th of June. Now, I understand why you're giving it to us, and because that's what was presented to them. But I would have liked to have seen an update of what was discussed at that meeting, because there is a number of reds past their date with no or minimal explanation of why the dates are being passed. And from what you've said, I think a lot of these actions have been completed. I think all of us are acutely aware of the feelings out there about vascular services, and I think we need to use every opportunity to give the assurances to the people of North Wales, give them the assurances that we are taking this seriously. And I would have liked a much more detailed, succinct report on what we have done to give us assurances opposed to the reassurances that you've given us today. I've also looked at the papers for next week for QSC, and they're not much different from what's here. So sorry I'm not being more positive on the written auditable tracks of what you've done.
Well, thank you, Lynn. That's very helpful feedback. I think what I can do is I can talk to the team about how we represent information. The request for the board today, and the paper was submitted, I think, on time, was an update on the external invited review. In hindsight, maybe we shouldn't have shared the information that's gone to QSE, but I thought it was helpful to give transparency over the work and the complexity of the work that's been undertaken. The report was submitted after one meeting, and I think it would have been difficult to accept and confirm all the actions in the first meeting. What we wanted to do is ensure that by the first meeting, we all started the conversation and got into a lot of the detail around the actions. And we're working to provide a report to QSE with more detail around those actions. I think it will take a couple of meetings to get into the momentum of this because of everything else that's happening. But I take on board, Lynn, we need every opportunity to give assurance to people that we're taking this seriously and we're not, that we're doing the work in the best way we can. And what the group has done, it has challenged some of those actions and has started to put some, I think, helpful constructive criticism in about the way that we might want to construct the action plan. And the action plan has been given to the Task and Finish group to own and to shape, and we will be doing that at each meeting. And I take on board the feedback, Lynn, and ensure that at the Quality and Safety Experience Committee, we give assurance, not reassurance.
So in that regard then, can you and Lucy pick up, Lucy being chair of QSE committee, one, the commission of the independent review, and secondly, the work around the plan, as you describe, it should be monitored and developed through QSE. So if you two can pick that up, but when you're satisfied that it's in the point whereby you can tell us the independent review has been commissioned and the plan is been worked through and is up to date, can that be shared with wider board too, given the level of interest around this topic, please?
Yes, of course.
Lynn, does that satisfy your concerns at the moment?
It does, thank you.
Thank you. Thanks, David. Okay, so we now move on to the maternity report, which details the review of maternity services by HIW. This is really an information item, I guess, Jill, but it's listed for discussion if there's anything you wish to discuss. Thanks.
I'm assuming everybody has read the report and it is for information, but I would like to put some other context around it, if I may. So this details the HIW process and the unannounced visits to our maternity services, both community and acute. And clearly it also touches on the governance expectations. And whilst this outlines the reporting mechanism and assurance mechanism, that we have processes in place where gaps have been identified by HIW to close them, I'd also like to give assurance that within QSE we're looking at the broader mechanisms that apply within maternity services. And I think in the QSE chairs reports that Lucy shared earlier in the meeting, there was, for example, an item that was presented to QSE and was subject to debate in QSE on postpartum hemorrhage, for example. So I just wanted to place that into context. As you know, also, this was a result of, in part, of the CMTAF maternity services concerns and was part of a broader governance piece. And as you know, the board did pull together their own response and actions as a consequence of that, which is due to go to QSE next month.
Thanks, Jill. Lynn, I think you've got a question.
The whole point of these reviews are to look at the quality of the safety of the services throughout Wales. We've now got a huge issue over the border at Telford and Shrewsbury. How will we be keeping a close brief on that, on what goes on there, to ensure that we don't have similar issues? And could you also give me an update on the issues at CMTAF and how we fit in? Thank you.
Okay, if I take the Shrewsbury, the SAFT issues, can I just advise that we're looking at, we're aligning very closely with those through our maternity services. So our director of midwifery is closely engaged in those conversations. And as you know, some of our patients will have been involved, some of our public will have been involved in some of the reviews of that service, because they will have accessed those services. So we're very closely aligned to that. But I want to take that broader, if I may, Lynn. So what we do see within services is repeated mistakes, and what we're seeing within SAFT is to some measure akin to what we're seeing in Morecambe Bay. So again, we are looking at all of those reports to ensure that we're confident that we're closing gaps. As a consequence of some of that, there has most recently been identified a learning opportunity around human factors, because a lot of this resides around human factors, which I am encouraging members of our, not only our maternity team, although it is focused on maternity, but some of our other safety leaders to attend, so that we can maximise not only our own learning, but get access to that learning from other organisations who are also focusing heavily on lessons to be learned from SAFT and Morecambe Bay. Sorry, in relation to the CUMTAF, as I said, you know that we did pull together a response to CUMTAF. We were asked to submit to Welsh Government. That is being currently updated and will be, as I say, presented to QSA, I believe, next month in August.
Okay, thanks both. So we are asked to note 3 things at the front of the report. I won't read them out, but I will assume, unless anybody says something contrary, that's what we're doing. There is an update on progress with the recommendations due at the final appendix, which are either listed as green or amber, but as I read it, those in amber are largely in amber because of a delay around the response to COVID and the disruption that's caused. So no doubt they will be progressed as we move forward. So
they will be, Chair, and monitored through QSG and any exceptions up to QSC.
All right, thank you. Okay, so unless there are any other questions or points to the contrary, we'll take that report as noted in the way described. So we now would move into decision items. So Mark, the Q2 plan we've touched upon already. This is for decision, but in essence is for retrospective approval because it has been submitted to Welsh Government in keeping with their expectations, and we are doing what other health boards have done in terms of seeking to approve it retrospectively. So without further ado, over to you.
Okay, thank you very much, Chairman. So this is the Health Board's draft plan for the second quarter. As you said, Mark, it's from the quarter 1st of July to 30th of September. Although it's our plan for Q2 and there are firm timescales around the second quarter, the plan is constructed with an eye on what we're going to do in later periods as well, because much of what we need to do actually doesn't fall neatly into a kind of quarter by quarter period. It doesn't really lend itself necessarily to those kind of planning timescales. So if I just use orthopedics, for example, as one example, the Q2 commitment is to produce a recovery plan for access to orthopedic services. The Q3 action at the moment, and this is a draft action at the present time, talks about the establishment of an orthopedics clinical network and clinical engagement and leadership. And then the Q4 draft action talks about reviewing and refreshing the business case. So it's a firm plan for Q2, but it seeks to place actions in their kind of broader and ongoing context. As you said, Mark, it was submitted to Welsh Government as draft on the 3rd of July, and we're meeting with Welsh Government colleagues. I think it's on the 31st, a week tomorrow, to receive their feedback following their review, and I'm sure that will be helpful to us. As important as the plan itself is the action planning that underpins the plan, because that's where we get much more specific about who's going to do what, by when, and crucially, what output, what impact can we expect that to have. And that's been shared with the board for the purposes of this meeting, and colleagues will hopefully have had the chance to review it, although in many senses it is more of an internal working paper and doesn't actually form part of the formal plan submission. I can advise that the action plans were supported by the executive team yesterday. There are a few changes that we made from the version that you've had the opportunity to review. Some of them were just tightening the drafting of it a little bit. I think there are 2 material changes that I want to highlight following yesterday's discussion at the executive team. The first is that the workforce arrangements in terms of which committees workforce actions are reported to were changed quite significantly. So we can talk through that if people are interested in understanding that detail. We also, at the time we sent out the version to board, I wasn't entirely clear about how we should deal with mental health reporting and which committees should be overseeing our important plans for mental health. We discussed this yesterday and agreed that we should follow the approach that I think Lucy has recently articulated for primary care. Namely, if it relates to mental health strategy, it should be reported to SPPH. If it relates to mental health financial and direct performance implications, it would go to F&P. And if it relates to mental health, quality and safety issues, then it would naturally fit within the QSE agenda. So that isn't in the version that you've got here, but will be the version that we will operationalise after this meeting. This paper itself has not been made available to the public yet, so this isn't on our website. The content was entirely supported by exec team. We need to do some work presentationally, changing from our names and initials to job titles, for example. We're also going to check with comms colleagues that it is as explanatory as it can be and a document suitable for public consumption. But the action plans will become in the public domain by the performance monitoring reports that will start coming to our committees in August. You asked the executive team, Mark, to identify the big ticket items for Q2, and are we clear about what those are? I think, unsurprisingly, many of those big ticket items are things that we've already referenced in our meeting today, but I just want to run through them so that we've got absolute clarity about what we as a team think are the most important items of all the many things that we are trying to progress, and indeed we are progressing at the present time. So I think the big ticket items are these. COVID is not over. That is the first thing to say. That's got two important implications for us that we need to be very alive to in Q2 and beyond. The first is the need to maintain an agile response should we see a second peak. And the second aspect of COVID not being over is the need to operate under severe operating restrictions in order to provide a safe environment for delivery of healthcare. So we've got two important items for us there. I think the third big ticket item relates to our need to reintroduce services across the second quarter, but to do that in a safe way, and that is absolutely crucial and must always be at the heart of what we do. I think there are two important programs there, and both of which have been touched on today already. The first is TTP. That is a crucial part of our response and a key multi-agency issue for us. And I think the second issue is the risk stratification work and applying risk stratification to our waiting lists. And I think that is another really important piece of work. It's great news that we are now operating a single BCU-wide approach to risk stratification. And what follows from that is that patients will be offered treatment at the earliest possible opportunity across North Wales. That is quite a significant change for some specialties, not all, in terms of how we have historically managed our waiting lists. And embedding that and progressing that is absolutely a big ticket item for us. I think it would be wrong if we were to lose sight of some of the longer term and some of the important foundations that we are laying over the next quarter. So we'll be looking at the digital health record later on today, and we've got the business case for the acute digital health record. Financial close on that procurement is scheduled for the end of September, and that will be a huge opportunity and a significant step forward for the health board, and I think it's worth amplifying that as an important component of our Q2 plan. We currently have an over-reliance on paper-based records. We regularly shift hundreds, if not thousands, of medical records up and down the A55 across all our different acute sites. That is a significant risk for us as a health board, and that feels particularly relevant at the moment with the pandemic. But paper records have got the fundamental issue that they can only be in one place at one time. So the making progress on the acute digital health record, I think, is a vast step forward for us as an organisation. It will take 3 or 4 years to fully implement. It's not a quick fix, but I'm very mindful it's one of those crucial foundation building blocks that I think David articulated a few months after he joined us. We talked about the 5 or 6 things that we needed to put in place. So I think it's fantastic that one of those is going to come to fruition in the second quarter. That will pave the way for a digitally enabled clinical strategy, which is another important theme for us as a health board. So I think that's all I wanted to say by way of introducing the Q2 plan to the board, Mark. I'll pass back to you, and I'm happy to take any questions on the plan.
Okay, the first point I think I need to make is, if the board is to have confidence in signing off a plan, it needs to have confidence that the things that are necessary to deliver the plan are in place. So to hear that the executive team as of yesterday has still not signed off the action plan when we're now close to 1 month into the quarter is concerning and by any stretch pretty unacceptable. So I would want confidence, first of all, that the material content of the action plan is capable of delivering the plan, because if it's not, then I don't see how we could retrospectively approve the plan. The second thing is, as you I think know, I'm not prepared to entertain moving forward, and I respect the timescales that you've been working to meet Welsh Government deadlines, but I'm not prepared to accept again the fact that we're still working on an action plan so far into the quarter, which is making the problem sit with the board to a degree in terms of governance. It's just not acceptable. So we are already looking to identify a slot on the 22nd of September and also the following week to ensure that the path through to clearance of the Q3 plan is in place before we enter Q3. And that is a key element of governance. So perhaps, Mark, you want to respond first to the comments I've just made. You're on mute, Mark.
Sorry, the material content of the action plans were approved by the executive team yesterday. I need to be very clear about that. The further changes that we want to make just relate to changes before it can be placed in the public domain. So it's presentational tidying up. The material content was absolutely agreed by the executive team yesterday, and indeed the implementation of many of those actions is well underway already. I do accept your point absolutely about the third quarter plan, and I think I've already shared, I think with Finance and Performance Committee potentially, if not certainly with the executive team, some of the timescales that we are working to in terms of preparing our Q3 plan.
Okay, thanks. Sue, I think you want to come in. Sue Green.
Yeah, I think it's just to support Mark. I don't know whether there's been a misunderstanding. We're absolutely aligned to the delivery of the plan and the delivery of those actions and the outputs in the implementation plan. This was merely around refining and making sure that we have a document that is accessible and understandable. So we're into the detail of what I've just said. Is it accessible and understandable? There's no question that we're committed to delivering the plan and are already underway with the vast majority of actions.
Okay, thanks, Sue. Lucy.
Thank you, Chair. First of all, in relation to the plan itself, certainly for Q3, and we did discuss this at the workshop, I'd like to see a much more integrated approach for this. As we discussed before, we've talked in the plan about demand and capacity for hospital beds, and I appreciate that it's been clarified now that's for hospital beds. But actually, as we've discussed before, demand and capacity is much greater than just that. And trying to be clearer, I think, on the demand and the capacity across the whole system it needs to be more visible within the plan. In relation to the action plan, and I appreciate all the comments that have been made there about it, there's just a couple of comments I wanted to make about that. We talked before about how important it was when we looked at the Q1 monitoring plan, about how important it is for the actions to be very clear and specific. And I still unfortunately see in these actions, I see some very, very high level actions that are just not specific, would be very difficult to measure. So an example being on page 16, talks about stroke services. Stroke services in itself is not an action. I don't know how that we would even measure progress against that. And then later on as well, it talks about wellbeing hubs. Again, that's what do we mean? What does that refer to? Again, that would be very difficult to then measure. And my final comment then is actually around the plans for mental health. And I appreciate, Mark, you've just explained to us about the reporting to the committees, but I'm concerned that the actions that have been laid out within this to support the mental health plan, they are, firstly, they include actions that actually we've discussed previously, need to be updated. So a number of these actions seem to be actually quite out of date, and they don't correlate with a number of discussions that we've had recently. In particular, it needs updating in line with those discussions, that the focus needs to be about Q2 COVID plan. And then there's a longer term improvement plan which requires appropriate consultation with both our staff and our partners, and it's a bit mixed in this document in relation to that. I've also discussed the absolute need for engagement with primary care, including the cluster leads and the LMC as well. This is absolutely essential if we are going to be looking at delivering any new services or new service provision processes or support within primary care itself. And I'm concerned that if this is being put in our Q2 plan now, that maybe some of those conversations, either they've been lost or that they themselves are missing the point. And that really does concern me, that at this point, as Mark said, we're at this point in the plan and we've still got all of that detail in there. Thank you.
So Mark, do you want to respond to the general points about the construct of the plan and the action plan? And then David, can you come in around mental health, please?
Yeah, thank you, Mark. Thanks, Lucy, for your feedback. So I think absolutely take the point about the plan needing to become more integrated, and we have discussed in other settings about the need to develop our capacity modelling in the Q3 plan, and we absolutely accept that challenge. It is a fairly bed-based analysis. I think you're absolutely right. It would be worth unpacking a little bit some of the specific areas that you've referenced in your feedback, Lucy. So one of those is the point about stroke services, and then the second one is wellbeing hubs. So yeah, absolutely, simply writing stroke services isn't an action. I think there's more detail provided in the output column there of what we are going to do. So I'll perhaps talk a little bit about that, and then other colleagues, potentially Chris, potentially Jill, may wish to come in. I think you'll be aware that we had a business case for the development of stroke services that we weren't able to progress last year, but the imperative to develop our stroke services remains. And what we're talking about here is to take our work on stroke services to the recently established clinical advisory group and essentially to update that using our clinical leaders to bring back a reconciliation of the previous stroke plan with what we now think is appropriate as we move towards adopting more of a pathway approach. So there is a clear deadline there. It sits with Chris as these services are managed by the area teams. We've got a target date of the 30th of September for that update, for that piece of work to be completed. And at least for me, Chris may well have a different view, for some kind of paper to come to the Finance and Performance Committee. So I think we are actually quite clear what we are going to do about that, and that is obviously right. In respect to the wellbeing hubs, yes, absolutely, wellbeing hubs is not an action. Perhaps just worth unpacking a little bit what we have in mind here. Review to be completed, re-priority of schemes is what we are talking about. We've got a number of health and well-being hubs developments that we have sought to prioritise and progress across North Wales, but I think our collective sense is that we've not made the progress that we would like to have seen against all of those developments, and they have been in a planning phase for some considerable period of time. A number of them, I think most of these actually predate my arrival at the health board, and I've been in post for coming up to 2 years. So these have been around for some time now, and therefore what we are proposing via this plan is that we simply review those schemes to determine whether they are still priorities for us as a health board, and to attempt to place them into some kind of priority order. We might find that difficult, but I think that is something that we should do. So again, just to provide the board with assurance that we are very clear, the output from that action will be a review of the scheme priorities that we've got for the various wellbeing hubs that have been in planning for some considerable period of time. And again, there is a clear expectation that work will be completed not much more than 2 and a bit months away from now, with a report to go to SPPH committee. So for me, I think those actions and what we're trying to do there, I think is pretty clear. Perhaps I'll just give colleagues the chance to see if anybody would like to comment either on stroke services or wellbeing hubs before I hand over to David to pick up the mental health issue.
Okay, thanks, Mark. Just to support what you've just said, I agree with you. It's a fair point in terms of the narrative in those fields. It's not suitable, and I think that really is partly what you've been alluding to in terms of how we need to translate and unpack some of the language in those boxes. It's not giving the necessary information to board members. It certainly won't give the necessary information to me as a member of the public if I'd taken the trouble to get the document and then read it. So we need to hold our hands up and accept the language does need to be changed, but we are clear in terms of what we need to do in both those respective areas.
Okay, David, mental health.
Thank you, Chairman. So I take on board the comments Lucy's made. We've had meetings most days actually, and I think the difficulty is we've submitted a plan and then we've had subsequent meetings and we want to change it. I think we're getting to the point where the plan needs to be simplified. We are sustaining the way the service works over the next quarter and quarter two. It's the safest thing to do because of the vulnerability of the cohort and actually the success of some of the changes we've been putting in place since the pandemic started. What I think we put into this, which I think we can put back, is some of the longer term changes so that we're cited on COVID in this quarter rather than the longer term of the division. But we are doing a lot of engagement and we've had a lot of feedback on the ideas, and I think we're in the process of reflecting on that in quarter two, sustaining the safe services but also starting to engage so that quarter three feels more co-designed, and I think that's a key learning point for the division, to work with stakeholders. I've spoken to local authority colleagues this week as well as CHC and members of staff. We're getting a lot of feedback in how people think we're adjusting to the pandemic and what changes we should be making in quarter three, quarter four. So what I'll be doing is looking at this, take out things that maybe are more aspirational that could be put back and after further conversations with people. But I'd like to keep the bits that we're doing that we need to continue to do. Otherwise we risk destabilizing the service. So the sustainability of the division is to carry on with the phase one work, which is keeping people safe, protecting the most vulnerable people, but engaging our stakeholders so that we co-design quarter three and quarter four effectively. And I'll make sure we reflect that in the text.
Thanks, David. Michael, I think you want to ask a question.
Yes, please. I was looking in this report for some of the work which I know is going on and I've participated in, which is hopefully temporary redesign of accommodation to achieve social distancing, and the realization that we can't suddenly bring back everybody to work in the way in which we've done in the past because we can't achieve social distancing. And I'm just wondering, in terms of the plan going forward, how much of there is a link between the plan and all the health and safety work that's going on in the board.
Yeah, if I can comment on that, Chairman, if I may, I think that runs through so much of the plan. We recognise that because of the safe environment guidance that we're now operating under and the imperative of providing a safe environment, that for all the reasons Michael has outlined, we'll be able to provide much less than we would usually provide with the same workforce. So all the bed modelling, the hospital zoning work, all the stuff that's happened out there across our sites in terms of signposting and social distancing, I think that has played through into the plan, and that presents part of the challenging context that we are now operating under. But yeah, absolutely, it's kind of fed through the plan, I suppose.
Okay, Sue Green, did you want to come in?
Yes, please, Chair. I think the other aspect that I would kind of highlight is a number of weeks ago we took the decision and we communicated out to managers that irrespective of changes in kind of lockdown measures, we shouldn't be returning staff who can work from home to the workplace until we've done the proper review across the organisation, and the kind of safe and agile working programme that I talked about a little earlier. The first priority for that is absolutely the health and safety of our workforce, but also for our patients. So reducing footfall in terms of our healthcare sites and settings is absolutely clear, a clear priority, particularly for those people who don't need to be on those sites. So I think there's a couple of things. One is recognising as we reintroduce some services and as attendances at our healthcare settings increases, hopefully from a patient confidence point of view, we need to be mindful of making sure that only those staff who need to be on those sites are on those sites. In terms of, I talked a little bit before about the risk assessment process for vulnerable and clinically extremely vulnerable. Clearly, the risk assessment process for any return to any workplace needs to be undertaken, and people shouldn't be returning to the workplace until and unless that has been done and the actions identified. So very, very clear that the absolute imperative at this stage is around the health and safety of members of staff, patients, and the public.
Okay, thanks, Sue. So we are asked to receive and approve the draft Q2 plan. I suggest we do so subject to any other comment, but we do so with the caveat that whilst we recognise all the work that's gone into this plan and the tight timescales that you were working to, Mark and team, we won't entertain again receiving a plan that's still being worked upon or actually does not adequately reflect, in our view, some of the comments that were made by independent members. So what is key, Mark, is for you and the team to ensure that there is a timeline before the Q3 plan is submitted that enables the feedback to be given, to be received, to be taken on board, or at least an explanation offered as to why it's not been before we enter Q3 next time around. Is that recognised and understood?
I think it is, Mark. Yes, thank you very much.
Okay, and then in terms of Q3, Mark, I suggest we offer comment outside as to items for inclusion. I think you've picked up on some of those in your opening. Also, there's reference to a number of items rolling into Q3 from this quarter's plan, but I think we can proceed with comment and dialogue around that outside of this meeting.
Yeah, we absolutely can, and we've got an SPPH committee coming up on the 12th of August. When that will also feature as a significant item on that agenda.
Okay, thank you. So unless there are any other comments, I'm now going to move this onto the risk management strategy. So Jill.
Thank you, Chairman, and thank you for the opportunity to bring this to the board for decision. This has been a complicated strategy to pull together, and I want to thank the input from IM and executive colleagues in bringing it to the board today. It's been subject to a lot of debate, and most recently through the audit committee. There are a couple of things I'd like to bring to the board's attention. And one of them is the recommendation through this risk strategy that we go from a 5 to 3 risk management strategy. That has been tested within the health board in the East area and has been well received by the teams there because they feel it's less complicated, easier to understand, and easier to understand the escalation. The other point I'd like to make is the recommendations about the risk appetite and the need to debate that on an ongoing basis as part of the board workshop moving forward. When we had they took this through the audit committee, and I'm sure Medwin will want to comment on this, there was a concern in line with all the things that we're being asked to do as part of COVID, whether we will be able to implement by October. So although approved, I think there was a concern we'd be able to do that. I'd like to update the board on the actions that have taken place since the audit committee. So we did agree that we'd have workshop with the board, one to identify our priorities for the coming years, and secondly to align those to our board assurance framework and corporate risk register. Both of those are now in the diary. Within the coming weeks. We are already in process of aligning the individual divisions review of risk to support the movement to 5 to 3 tiers, and we have assigned corporate risk team members to each of the divisions to facilitate that. The additional resources, which I think was acknowledged, that we would need additional resources to get this out at the time speed that we want it to, but also to ensure it's embedded as part of the organisation, were discussed at the exec team and supported yesterday. And the final point I would like to make is this needs to be seen in line with the revision in governance that is taking place in parallel across the organisation. I'm happy to take questions. And as I said, I'd just like to reiterate my thanks, particularly to some of our IM colleagues, to help him frame and shape this to get it to the position it is now.
Thanks, Jill. Okay, John, I'll open it up to you first.
Thanks, Mark. I think the first thing is just to endorse the approach that's here. I think, there's been a number of conversations and I totally agree with the approach that's been taken. I think the concern I've got still, because I've raised it previously, is one of detail, but there are key elements to risk in terms of defining the impact, the likelihood, and the inherent risk. Yet that's not documented. So there are key fundamentals in terms of definition of how risk is put together that are not communicated here, and I believe that it should be in the document, but I have raised that previously, and it's not there. So it may be there's a judgment to say it shouldn't be, but then how's that going to be communicated back that there's a difference of judgment?
Okay, John. Sorry. In answer to that, there is an implementation plan that we have developed alongside this, and I think that is actually part of the education of our staff and in terms of that assurance. So I think that's what we haven't ignored that comment. It's just whether it's part of the strategy or part of the implementation.
Thanks for that, Jill. I think it's just for me is that we've at the beginning of the document that in section 3 is the definition of key concepts, and for me there are 3 key concepts that are missing. That from previous discussions I thought were going to be included, but they haven't been. I don't think it's changed at all from previous versions. I agree it should be part of the training, absolutely.
Okay, thanks both. Lucy?
Thank you, Chair. I just wanted to say in relation to, I think it's important to note in relation to this strategy that this is just the beginning of a much wider and much needed piece of work across the Health Board, reviewing our risks and our risk appetites. I think, again, what COVID has shown us is that it has changed our risk appetite, and that has, I think, given us a much needed prod, although, you know, this work has been ongoing now for a while and was slowed down a little bit, unfortunately, as a result of COVID. But it is just the beginning. There's a lot of work still to do, but we're absolutely on the right track, I think, and I'm very supportive of the revised approach. Thanks.
Thanks, Lucy. Medwyn, any comment from you as Chair of Audit and the fact you've been involved too closely in this?
Thank you, Chair. Yes, so just to concur with Jill, basically, we need to be looking at the risk appetite moving forward, but we're in COVID-19, and the main concern, even though the Audit Committee approved the strategy in principle, was the implementation date being the beginning of October. And one of the main concerns was the number of Tier 5 to 3 that needed to be looked at in terms of moving forward, and also the training involved given the current situation we were in. And I realise we're having workshops coming up in the next couple of months to discuss this and to sort of thrash it out, basically. But it was that implementation date which was the main concern, not the actual strategy itself, because as Jill alluded to earlier, it seems to have been positive feedback from the East, which is to be welcomed, of course. So the strategy was approved, but we need some assurance that things will be in place by the beginning of October.
Okay, Jill, do you want to respond to that?
So, yes, I'm happy to respond to that. And we had conversations with this as a team, and as I outlined within my opening presentation, work is already being undertaken across the Health Board to do the cleansing validation exercises to move from 5 to 3 tiers. So that is already taking place, and it's taking place at pace because we've been discussing this across the organisation for a while. I think critical to this is the board, the piece where the board is looking at the board appetite and populating the highest risks to support the divisions in the prioritisation from board to ward and ward to board. And when I talk about ward, I mean that in the broadest sense, because it obviously applies to our community settings and our GP settings.
Okay, thanks, Jill. So unless there are any other comments, we're asked to ratify the approval of the risk management strategy and policy and to note the delay around the 1st of October, but Jill's already explained that in terms of what's being done. Are we happy to ratify and note?
Yes.
Yeah.
Yes.
Okay, thank you. Thank you. So we're moving off of those items onto information items, and there are a number of documents that have been circulated which are listed for your information, colleagues. So no doubt you will have seen them. So I now move on to closing the business of this public meeting. The date of the next meeting is the 24th of September, and the annual general meeting will be on that date, starting at 09:30 hours, and the board meeting will follow at 10:30 hours. So at this point, I exclude the press and the public, and will therefore now stop the live screening.